all of you. I welcome you all for this 10th Onco update. And without much delay, I hand over the proceedings to Dr. Akash Tiwari. Dr. Akash Tiwari, are you there?
Yes, sir. I'm here, sir. Good evening, everyone.
Dr. Akash Tiwari, are you there?
Yes, sir. I'm around, sir. Good evening, everyone. Upfront, I like to invite the first session we know is on the breast cancer, and there have been a lot of development in recent times in this sphere. For the first session, I like to invite Dr. J.P. Singh sir and Dr. Nafees Siddiqui sir to chair the session, call on the moderators, and from here we can begin this feast of academics today. Thank you. Sir, please.
Good evening. Good evening to all of you. I think we are going to discuss today a very important session that is related to HER2 breast cancer and the management, latest management of it. I think the first topic of this session is the shifting paradigms in HER2 positive early breast cancers. The speaker is Dr. T.P. Sahu. Doesn't need any introduction. Very renowned person, very talented person, and I think is known to everyone in India. All the oncologists knows him. So it is our best time to hear him regarding this particular topic. Recently, I think molecular subtype of breast cancer related to hormone receptor and HER2 new status has been in practice for the last many years. The survival rate among patients differ, that is based on the molecular subtype and stage. Now it has been accepted the fact that HER2 overexpression is associated with higher rate of disease recurrence and mortality. During last 2 decades, the treatment with trastuzumab in HER2 breast cancer have shifted the entire scenario dramatically. Despite the improvement in pathological and complete response and event-free survival, 15% patients would relapse after the therapy with trastuzumab due to resistance to Herceptin. Therefore, additional therapeutic targets with different mechanism of action like pertuzumab, like docetaxel, lapatinib, and niraparib, added with Herceptin have been extensively studied so far. Recent ongoing studies about this particular combination of different drugs with Herceptin has resulted in a better outcome related to progression-free and overall survival. I think we have a very, very learned speaker who will enlighten us about the various issues related to this particular topic, and I think we'll certainly be benefited by his grand talk. So with this, I call upon Dr. T.P. Sahu for presenting this his talk, please.
Good evening, sir, and thank you for those kind words. And before I can start, I'll just compliment Akash. He's looking at least quite young with his new shave and everything. So Akash, keep it up, and yeah, you look good. So I thought I'll compliment you before I start off. And Singh Saab to Hamisha is, I've known him for quite some time, and thank you, sir. And thank you. I've learned a lot from you. Thank you, sir. And in next 10-15 minutes, I will just try to look into my job that's given is the early breast cancer and HER2 new positive. So I'll be brief, and I want to touch few things that have changed. Some of these things have changed over the last 2 to 3 years. Some have changed over the last year. But one thing is sure, that this arena of breast cancer is changing very fast. We have had a lot of new drugs coming up in hormone positive. Now HER2 new positive breast cancer always was a field where targeted therapy was the choice of therapy, and suddenly we have a plethora of drugs. But unfortunately, for the average Indian, these are beyond the reach. Till we have a generic TDM1, probably even that generic TDM1 in my practice is only in the reach of very upper middle class. The lower and the lower class really cannot afford such a costly drug like the generic TDM1. Trastuzumab, thanks to the generic companies, is now affordable. So I think this field is now very, very exciting. So I'll start off with the adjuvant and then shift focus to the new adjuvant. So in the adjuvant, if you look at into that's let's take a case in scenario, a 60 more than 60 years old patient had a lumpectomy done, and the sentinel lymph nodes showed and the biopsy showed as invasive ductal carcinoma, and all the nodes were negative. So we have a T2 less than 3 centimeters, N0 M0 with ER/PR strongly positive. HER2/neu is also positive. So what exactly would you do on the adjuvant scenario? And if you look at it, there is the trial, and especially we have used this trial, the APT trial. And this trial, before I come to it, all of us agree that HER2/neu by itself is a poor prognostic factor. These patients in metastatic disease develop a lot of brain mets. But per se, if you look at HER2/neu status, if you're not treated adequately by targeted therapy, the chances of relapse are much, much, much higher than if you treat with a target therapy. So the APT trial in question, I'll make two just points because this has been a trial for last 4-5 years. We have talked enough of this trial. The good thing about this, you can give it in elderly. Sometimes in India, we have overused it. We have used it in the segment where the trial did not know, we do not know what happens because the trial was very specific. It is early and very early, node negative, less than 3 centimeters. And this, if given the right patient, especially if they're hormone positive, then this trial did show that you could achieve a survival that is approximately touching 96-97%. And this is something huge, terrific, beyond 95. And when we look at these patients, whom we always felt was looking at a very poor subset, but this patient with a little bit downstaging of chemotherapy, with only weekly paclitaxel for 12 weeks. Trastuzumab, mind you, if you give such a chemotherapy, which is not the probably standard of care or probably a curtailed chemotherapy, you are not going to curtail trastuzumab. You have to go for that 1 year trastuzumab because you just cannot do 9 weeks of trastuzumab and also at 12 weeks of paclitaxel, or you probably even can't do a 6 months of trastuzumab in this patient. In this patient, if you are doing a weekly pacli, the APT protocol trial, I would go for a year of the trastuzumab and not go for the 6 months, which we normally have shifted if you are giving anthracycline and taxanes. Now, if you look at it, and this case, yeah, and when we move forward, and we know that TDM1 has taken a space, and especially after the new adjuvant Catherine trial, it has taken a space in adjuvant. And this ultimately, the attempt trial was done. It was a phase 2 trial. The stratified patient with a very early breast cancer, HER2/neu positive, microscopic node positive or N0 with good ejection fraction. They looked at TDM1 versus paclitaxel and trastuzumab, exactly the APT type. And what they wanted to find is the 3 years DFS in TDM1. And also they wanted to compare if the TDM1 has lesser toxicity and the cutoff was 40% lesser than the standard arm. And in this patient subset, if you look at it, there's nothing much to look into. But if you look at the 3 years disease-free survival events, and that's in the lower part of it, you do find that APT protocol did score over the TDM1. And here, my point of contention was these were equal protocols. And also the toxicity did not touch the margins where it should be. And if you look at it, attempt did not meet the CRO primary endpoint of 40% reduction in toxic TDM1. So with this, I think still APT or trial or the PACLI plus 1 year of trastuzumab looks the standard of care in this early HER2/neu positive breast cancer, less than 3 centimeters in size and node negative. What do we do with the high risk? Those are higher T size and node positive. And here, can we get away with a shorter course? Can we get away without chemotherapy, or do we need to do something more? Definitely, we have been practicing chemotherapy, anthra, followed by taxanes and trastuzumab for a year. We have also had protocols with TCH where we have taken out anthracycline, just gone on for a year of trastuzumab with docetaxel-based chemotherapy. But here, when we look at it, it was the first trial, the affinity, which looked at chemotherapy plus trastuzumab, pertuzumab versus chemo plus trastuzumab and a placebo. a big trial of around 2,500 patients in each arm. And what they looked at into is the take-home messages. There was the advantage of adding pertuzumab, although the world did not, or probably Indian oncologists did not accept it because the cost of pertuzumab was very high and the benefit was very, very marginal. But if you look at the benefit in node positive in terms of IDFS, it was approximately 4%, but it shrinks to around 1% when you do in node negative. So you could probably give this protocol in a patient who is node positive, and if it is still 3-4 nodes, it is good enough. There is also data that if there is large bulky, more than 10-15 nodes, the benefit again little shrinks because of the percent that the disease is so bad. But this is a drug that should be offered to the affordable patients. And now we move to again to the adjuvant in the high risk to new breast cancer. And if you look at it, this is patients, can we do something more? We have done chemotherapy, we have done dual therapy or done a trastuzumab. Can we do something more for this patient? And for this, we have the trial, which was after the patient completed chemotherapy and trastuzumab as per the standard of care. And within 2 years of completion of trastuzumab, the node positive patients or residual disease patients after neoadjuvant therapy with a known ERPR status, if you look at it, was randomized to niraparib and placebo. And this trial, if you look at it, for the hormone positive, especially, there was a benefit. And the patient who were started within 1 year of stopping of trastuzumab did benefit, and especially hormone positive without PAT-CR to neoadjuvant within a year of the last of trastuzumab was probably the best segment of patient who did benefit from extended use of niraparib. But mind you, it is a toxic drug. Diarrhea has been a common complaint, but there are ways how we can look into the diarrhea. Now we go to the neoadjuvant. This is where the adjuvant stops. So in Indian scenario, how I practice adjuvant for me, it has always been a trastuzumab, because if you do Ayushman Bharat, it is not more than 9 weeks, because then the proposals is rejected by the insurance company. If it is a middle class family for me, I go for 6 months. That's what the evidence is. But if something was afford, I definitely give the option of a year. I don't tell them that 6 months is okay. But if there is something as a chemotherapy of single agent taxanes, I do not compromise on the 1 year, or even for a TCS protocol, I would go for 1 year if there is no anthracycline given. So now coming to a case where it is a locally advanced node positive breast cancer, what would you do? Now we have shifted gear. And after that, if you look at it, today it is not about operating. It is about whom not to operate and give a neoadjuvant therapy. And because there's a target, there is a chemotherapy. And if the patients do achieve a PAT-CR, the chances of them surviving is much, much, much better. There were 2 trials. One was the Neosphere, which was a 4-arm study. But the other one was a trial that looked up into different types of protocols. But the main aim of the lower one, the phase 2 trial, the Trifena, was to look at the cardiac toxicity. It was not, mind you, not for this looking at the response primarily. It was majorly a PAT-CR, but the primary thing what they want to look at is the cardiac toxicity. And if you look at it, the Neosphere, the PAT-CR was the endpoint. And if you add dual therapies, that is pertuzumab and trastuzumab, it was better in achieving PAT-CRs than if you do not. So that is take home number 1. All the protocols, if you give a dose dense AC versus the FEC, what we give standard, there has been no additional cardiac toxicity. That's also something that we see that has been shown by the other trial. So one more question. Should I be adding anthracyclines into the skeleton of a neoadjuvant therapy? The phase 3 TRAIN-2 trial showed that if you look at the schema, it was a good ejection fraction, WHO PS of 0 to 1, stage 2 and 3 with no prior therapies. They were randomized to non-taxane versus 3 cycles of taxane followed by a dual therapy plus the docetaxel-based chemotherapy and carboplatin. It showed one thing. The endpoint was addition of anthracycline in this setting, in this subset of patient, did not add. So basically, the thing would be, if I'm using a dual HER2 targeted therapy, I probably will not add anthracycline because in the randomized trial, it did not show any benefit. This is what it was all about. The last thing, can we do something without chemotherapy, or can we do something that the patient does not, or only we give a very short therapy. So this is the ADAPT trial. There were two arms, trastuzumab, pertuzumab, that is the chemo-free regimen, versus trastuzumab, pertuzumab, paclitaxel for 12 weeks. And if you look at it, the two things that stand out very quickly, that addition of the chemotherapy and dual therapies do matter, and patients who are good enough to achieve a PAT-CR, then adding no more therapy also is good enough, because they do not much benefit. So patients with who achieves a PAT-CR and probably with a taxane and the dual targeted therapy for HER2/neu, if they do achieve a PAT-CR, you are good enough to take away the component of the chemotherapy. I think the parallel can be drawn to the triple negative breast cancer with the addition of pembro and chemo. If you achieve a PAT-CR, then probably you can get away without much of additional pembro. So we are learning to now target the look at the neoadjuvant trials in a very, very different way. Now look at the other way. If there's a residual disease, what do you do? I told you, if there's no residual disease, you probably can alter your therapy and probably can take away chemotherapy. But if you have given a good HER2/neu targeted therapy, plus if you have given a chemotherapy and then you operate it, and post-surgery you do find a residual disease, this was Catherine, the randomized TDM1 versus trastuzumab, and when they looked at this study, it looked as that patients who did not achieve PAT-CR to the previous neoadjuvant therapy plus HER2/neu targeted, it would be prudent to give them TDM1 rather than continue with trastuzumab. So this is probably a thing why I would advise all my patients neoadjuvant chemotherapy at least for beyond 2 centimeters of size of T, HER2/neu positive or node positive irrespective of T size. Every patient should be offered a neoadjuvant chemotherapy plus a single versus dual. If dual can be given, very good. And based on the PAT-CR, you may just tell the patient to continue with the target therapy. And if you do not achieve a PAT-CR, you have every right to add TDM1, which will give them a superior survival. So this is what the guidelines is. How are we shifting? Just look at the Destiny Breast 05 and look at what happened to Destiny Breast 03. The trastuzumab deruxtecan has become now superior to TDM1. Now in the 05 trial, it is being tried in the adjuvant setting, and that is how fast these drugs are moving. And the tucatinib has been a success story with the Herculine trial in the metastatic setting. Again, we are seeing tucatinib being tried in the early breast cancer. So what I mean to say is the things are moving very fast. Every year there are new things coming in. But the most important take away from me is offer neoadjuvant therapy for patients with breast cancer. The only segment of people I would not probably offer is patients who are hormone positive. I really do not know much how do we alter the therapies. There's although a lot of data coming on the option of Ki-67 decrease post-hormone neoadjuvant, but still I feel triple negative and HER2/neu positive subset now not offering neoadjuvant chemotherapy, offering surgery directly for anyone beyond 2 centimeters or a node positive is not going to do justice to the patients, because you can alter your post-treatment surgery chemotherapy as per the response. So for a very early T1 or maybe less than 3 centimeters node negative, you can do a short chemotherapy of 12 weeks of weekly Pacli, but do 1 year of trastuzumab. Anything beyond that, neoadjuvant therapy is the standard of care. But if you cannot do neoadjuvant chemotherapy, someone operates. If you have a node positive, then you have every right to give a taxane-based chemotherapy with the pertuzumab and trastuzumab. But if it is not in the Indian scenario, what we do, anthracycline and taxanes with a 6 months of trastuzumab is something which I practice still. If the patient does not achieve a PAT-CR, I've already told what you need to do. So this is where I stop. And this is where I think the change has happened in the early breast cancer, especially in the neoadjuvant and the adjuvant, but more so in the neoadjuvant scenario, the things are changing very fast. Thank you, sir. Sir, you're muted.
Thank you, Dr. Sahu, for your excellent deliberation. I think we are running short of time and we have to conclude at 7:30.
Dr. J.K. Singh,
Yeah.
sir, since Dr. Vamshi Krishna is not there, he will join after 8 o'clock. due to some emergency patient. So,
Mhm.
with your permission, can I request Dr. Sahu to give some insights on HER2 positive, HER2 new metastatic breast
Yeah.
cancer?
Please. Yeah, you can do it. Should I call him?
Yeah, sir. Yeah. Dr. Sahu, you're
Huh.
muted. You're muted, sir.
Now the second topic is treatment of HER2 positive metastatic breast cancer, Indian scenario. And since the speaker, Dr. Mansi Krishna, is not available, so I'll request Dr. Sahu to take up this particular topic and educate us about this Indian scenario problems. I request also my co-chairperson, Dr. Nafis Ahmad Siddiqui. He can call upon Dr. Sahu and he can introduce the topic also. Dr. Siddiqui, is he here? Dr. Kars? Yes, Dr. Siddiqui?
Yes, sir.
I think, yeah. Please take up this topic and conduct, and you can call upon Dr. Sahu to conduct this session. Yeah.
Yeah, with the permission of the chair, I'll move on, sir, because I think we
Okay.
have to finish on time. So this
Yeah.
will be a very short one. Vamsi was to speak on HER2 new positive on the Indian scenario. I'll give my inputs. It was something which I was told, I volunteered to do it actually 5 minutes back when I was told that Vamsi is not there because the panel is there. I think it will help the panel. I'll go very fast. In the metastatic scenario, again, a lot of changes have happened. I'll go to 2 or 3 trials, which are major trials. Basically, if you look at it, why pertuzumab is there along with trastuzumab, because the domain site where they are put forward on the extracellular domain site are different. Pertuzumab is on the domain 2, if I'm not wrong, and trastuzumab is on the domain 4. If you look at, there are other small TKIs, the lapatinib, the niratinib, and the tucatinib, which are very small molecules which work at intracellularly. And the TDM1 is a drug antibody conjugate with the arm which attaches to the extracellular domain, and then the chemotherapy part, the TM1 part goes in, and it is engulfed by the endosome, and where the cytotoxic things happen. So first thing, what is the standard of care? It has been the Cleopatra way. If you have a patient with a stage 4 metastatic breast cancer, if it is affordable, then it has to be a docetaxel plus a pertuzumab and the trastuzumab. The docetaxel stops after 6 cycles, and then the target therapy dual continues. It has shown to be superior to the doublet, that is trastuzumab and chemotherapy. If someone who had failed the standard first-line chemotherapy, the targeted therapy dual or single agent, what to do? We always used to go back to lapatinib and capecitabine because that was the best available. It was cheap. Then came Emilia, which proved that the TDM1 was superior to the lapatinib and capecitabine combo, and this is where it was. So in the first line was a chemotherapy plus trastuzumab, pertuzumab, but normally in Indian scenario, because of the cost is not there, people do go ahead and give chemotherapy plus trastuzumab. And once that is there and you have failed, then the standard of care has been TDM1, but it is superior to lapatinib, capecitabine. But I feel still a lot of the capecitabine and lapatinib has been given just because people cannot afford TDM1. This is one more thing that has come up in the ASCO this time, Destiny Breast 03, which was speaking in, which I was mentioning a few minutes back. This was a patient who had failed trastuzumab and taxanes. And because TDM1 was the standard of care, this was compared with trastuzumab deruxtecan, which was a new contender. And it is considered to be little more superior because the antibody is 8:1 complex versus 3.5 odd to 1 for TDM1. To cut the thing short, this proved and was positive for the primary endpoint of PFS. The hazards was a staggering 0.28, that is a 72% benefit of the new drug, the deruxtecan trastuzumab versus TDM1. And the OS, although immature, is starting to show some early benefits. The best thing that happened in this is, with the deruxtecan trastuzumab drug, there is rarely a progression. Nearly everyone responds, and that is something that is really marvelous to look at, because in a patient failed first line, in a second line, to have no progressions is something as a dream. But if you have to remember, there are toxicities. This new drug comes with toxicity, and pneumonitis was a big toxicity. for a patient which excluded patients with pneumonitis. 10% of the pneumonitis, 10% patients in this trial developed pneumonitis. Hercline was again a tucatinib trastuzumab capecitabine versus a trastuzumab capecitabine versus and placebo. Again, it was patients who had failed pertuzumab, trastuzumab, and TDM1. This means two or more lines of therapy. It was again a positive trial, and tucatinib is a drug which every one of us is looking forward to. Apart from the deruxtecan trastuzumab, it increased the PFS, it increased the OS, and it decreased the patients and benefited very likely. This is the drug to look for if you have a relapse post first line with a brain mets, because the response to brain metastasis is excellent, and that is how people look at it. For hormone status, you can use it irrespective of the hormone status. Safety, definitely slightly more toxic. I'll just leave this part that the Nala trial was not very impressive for me. It was niratinib capecitabine versus lapatinib capecitabine. I'll just shifting gears. I'll go to two more trials and then stop. One is this TULIP trial, which was trastuzumab duocarmazine compared to physician choice of drug. And this drug has shown to be superior, and this was patients who had failed 2 or more lines. And if you look at it, it was patient heavily treated, and it did show a PFS benefit. The hazards was 0.64. So you have approximately a 35% benefit of the new trastuzumab combination versus what it is going to be standard. Okay, 1 minute, sorry. So, yeah. So if you look at it and going forward, the OS is not that significant, but the PFS is significant. So how do I look at the things, how people would look at? One more thing I'm looking at is, this is important probably. I'll take half a minute and then go to the conclusion slide. HER2 new is a new entity. Means patient who are 1 or 2 positive by ISC. We always used to do a FISH for patients with 2 positive and then take those 70% who are positive. But if you do not have a FISH positive, but positive on ISC, because this type of tumors are more in the metastatic than in also primary, and there is some trial going on in Destiny 04, and this is looking at the deruxtecan trastuzumab versus recent drug of choice. And if this is positive, I think we will have one more target for the low positive HER2 new breast cancer metastatic. So how do I look at it? If a patient is failed taxane, trastuzumab, pertuzumab in the first line, for Indian scenario, it will be taxane plus trastuzumab alone. The drug of choice at this point would be a TDM1. But then if this patient has a significant CNS disease, then tucatinib is the drug of choice. If doesn't have, then trastuzumab deruxtecan becomes the drug of choice. And then you have a lot more options like niratinib, capecitabine, the Marget tuximab, which is a FC engineered trastuzumab, again is a choice which is there. The TULIP trial showed one more choice which is again there for us. So multiple choices are coming in, but unfortunately all of them are very, very costly. So in the Indian scenario, it will be taxane, trastuzumab, followed by probably the capecitabine and the lapatinib. And after that, I feel very few can afford anything beyond that. The generic TDM is also out of the reach of a lower middle class even. Beyond that, I feel it is only chemotherapy and chemotherapy and chemotherapy. But with the affordable class, now I feel the trastuzumab deruxtecan is going to replace TDM1 in the post first line failures, and TDM1 will be pushed down. The only lacuna will be TDM1 activity in the later lines is not that we don't have solid data for that. We have data for the activity of trastuzumab deruxtecan in 3rd and 4th line. But is TDM1 active in 3rd, 4th line? Will the activity be significant is something only we will know as we start changing our practice. So with that, I stop, and I've given a real briefing of how the scenario of the metastatic breast cancer is also changing. So thank you, Bharat. Thank you, organizers. Thank you, chairpersons, for giving the opportunity.
Thank you, Dr. Sahu, for such a nice presentation. We are really very much benefited with this nice presentation. I think we move to the next topic, that is about the panel discussion. And the topic is de-escalation strategy in HER2 neopositive localized breast cancer. Moderator is Dr. Subhas Agre, and the panelists are Dr. Indrani Joshi, Dr. Deepak Sandrial, Dr. Nitin Chaudhary, Dr. Adya Murli, and Dr. Samir Srinagwa. With this, I will request Dr. Subhas Agre to start the discussion, please. Dr. Subhas Agre.
Thank you, sir. Thank you for the kind words. I would like to thank organizer Dr. Bharat for giving this opportunity. Actually, I was roped in for this particular moderating this session at the last minute. So whatever the time I could get during this particular time, I tried my best to bring the particular points on the table. So I would like to ask my panelists. I think only 3 panelists are going to join for this session. So I would like to, so Dr. Indrani Joshi is there. Dr. Indrani Joshi. Hello.
I think
Hello.
she's not.
Yeah, she's there, sir.
She's there.
Yes. Who else are there? Dr. Bharat or
Dr. Deepak is there, Dr. Deepak Sundaryal, then Dr. Samir Singrawar, and Dr. Bharat Chauhan is also, we can ask Dr. Bharat Chauhan to be in the panel also.
okay, right. So shall I start with the discussion?
Sure.
So my first question would be to Dr. Indrani Joshi. So what the de-escalation strategies will come to your mind when we talk about the HER2 positive early breast cancer? Dr. Indrani.
Sir, she's on mute. I'm calling her. By the time, can we move ahead?
So Dr. Bharat, can you take on this? Can you answer this question? So de-escalation strategies. So what factors that you would like to consider, and what will be the strategies that will come to your mind when we're talking about this particular subset of the patient?
Basically, Dr. Swaz, basically we have to see the high risk features and the number of nodes involvement and the age group and everything we can see, and then we can decide that whether we can give these patients a therapy which can be tailored to them and which can be curtailed, like 3 months, 6 months, and then we can take a call. Basically, I think I'll look at number of lymph nodes, grade of the tumor, and the high risk features and the age group.
Okay. So Dr. Deepak. Hello.
Yes, sir. I'm hearing.
Yes. So what is your current practice as of now for this HER2 positive early breast cancer? What is the current standard of care that you would like to have in the clinical practice?
Sir, if we look at the de-escalation part, so basically we will be aiming at 2 strategies. First, to how to de-escalate the chemotherapy part, and secondly, how to de-escalate the targeted part, anti-HER2 part. So obviously,
Exactly.
as Dr. Sahu has also mentioned in the previous lecture, yes, those patients who have less than 2 centimeter tumor, node negative, HER2 positive, yes, based on app trial, we follow the paclitaxel trastuzumab combination for these patients. And for those patients who have again node negative disease, small size tumor, we try to persuade them to complete 1 year of trastuzumab therapy. However, if the risk is low and they are non-affording for the complete treatment, we would like to give them at least 6 months of trastuzumab therapy, because the maximum benefit of trastuzumab should occur by this time. So this is our strategy.
So suppose with this APT trial, when you consider for early stage, maybe either a T1 lesion or maybe T2 some lesion, and so whether you will be comfortable using this particular regimen even for the 2 to 3 centimeter tumor and maybe with the hormone receptor negative tumor?
No, I'm comfortable in both settings, but mostly if the patient is an elderly in which there is a cardiac risk, and those patients who are node negative, only in those patients. Otherwise, if there is any risk factor node positive, size is more than 2 centimeter or 3 centimeter, I will be happy to give them complete chemotherapy arm plus anti-HER2 therapy.
So basically, suppose with the very low risk group, you would like to consider APT. Otherwise, you would like to go ahead with the standard established treatment option, right?
Right.
Suppose it may be either a hormone negative or maybe a slightly larger size of the tumor.
Yes.
Right?
Yes.
So, Dr. Samir is there, I think. So, Dr. Samir? Dr. Samir? So I think now, Dr. Bharat, are you comfortable using TDM1 in particular, this particular subgroup of the patients who are HER2 positive early breast cancer? TDM1 in the adjuvant setting.
Yes. I think Dr. Samir is also there. I've seen his name. And I feel what Dr. Deepak has mentioned and what you are mentioning and what Dr. Sahu has mentioned, I think I'm comfortable in using these TDM1 in adjuvant setting in certain group of patients. I think it's good, and the data is also good, and one can use and get benefit to these patients. Samir, are you there?
Yes, sir. Yes, sir. Just actually, I was seeing one patient.
Samir, can you?
So Samir, I can ask you a question, Samir.
Yes, sir.
Hello. Yes,
sir.
Suppose there is a very early stage breast cancer, node negative, favorable risk factor. So when you consider about using APT trial versus maybe TDM1, what will be your preferences and how you will select your patients amongst both these available treatment options?
Sir, less than 2 centimeter. Basically, if you see the APT trial, means number of patients included, almost 90% of the patient had tumor less than 2 centimeter. So, although it was the cutoff was 3 centimeter, but maximum patients were less than 2 centimeter in size. Only around 10-15% of the patient were 2 to 3 centimeter. So basically, if the lesion is less than 2 centimeter, I have no doubt I will go ahead with upfront surgery and just set Dana-Farber or Tolani regimen I will use in adjuvant setting. 2 to 3 centimeter, I think it is plus minus. Either way is okay. And after 3 centimeter, I will definitely go ahead with NSCT, and then adjuvant will depend on whether patient has acute PASCR or not.
So now we are having a patient who is less than 2 centimeter tumor, HER2 positive, right? So whether you would be going ahead with the paclitaxel trastuzumab based treatment regimen versus TDM1 apparently. I wanted to just highlight importance whether you between these two regimens, as now we are having a phase 2 attempt trial which has shown the benefit of TDM1 also in this particular setting. So how you would select between these two regimens, and you will be comfortable with which of these regimens?
Sir, I would be comfortable more with paclitaxel trastuzumab rather than TDM1 because I have not used it. But I think slowly how the data evolve and people start getting more experience with this drug, practice may change. But currently, I would go ahead with paclitaxel trastuzumab because these are also very less toxic regimen. Means I don't think paclitaxel trastuzumab will be more toxic than TDM1. So basically, TDM1 is again taxane only, but that is more of a drug conjugate, antibody drug conjugate. So I think, and cost-wise, paclitaxel trastuzumab would be much cheaper to the patient. So I think practice may change slowly, but at present, my practice will be taxane trastuzumab only.
So yes, I do agree with Dr. Samir also. So when we compare both these studies, basically with the TDM1, one will be the limiting factor will be the cost, but secondly, although the outcomes, that is 3-year DFS was slightly superior with the TDM1, but the rate of the discontinuation with the treatment were quite high. That is almost 6 versus 17 to 18% with the TDM1. And so considering that particular aspect with the more rates of the discontinuation and the cost, and maybe we don't have that kind of long follow-up, I think we will be more comfortable using the paclitaxel and trastuzumab with this particular subset. That would be my ultimate conclusion. If anyone differs from this, they can take on this also.
Dr. Sahu, Can I come in, Samir, for just I could intervene for a minute?
Yes, sir, yes.
I think we are looking at the attempt a little in a different way. I think the attempt was mainly to look at a lesser toxic adjuvant protocol. And if you look at the primary endpoint, it was to look at, that's why there were co-primary endpoints, that this drug has to be something more efficacious, probably TDM1, and also lesser toxic by 40%. So that's why I will always consider this drug as a trial as a negative trial, because it did not achieve what it meant to achieve. And TDM1 was found to be not achieving on the toxicity parameters. If you look at the primary endpoint, all the co-primary is there for this. It mainly look at whether the TDM1 regimen is lesser toxic. I don't think we should be practicing adjuvant TDM as of now for patients. The only role of TDM adjuvant will be for Catherine, where you are given a new adjuvant, targeted HER2 and chemotherapy, not achieved a path CR, and then only you should go for TDM1. That's my take. I think others can differ. That's what I look at.
Exactly.
South, sir,
Huh.
what do you think if the tumor is 2 to 3 centimeter node negative, clinically and radiologically? So in that case, what you are doing? You are giving NSCT or you are doing upfront surgery?
Ideally, you should be, as I told in the talk, everyone in the breast cancer, there is a trial which I'm forgetting, even beyond 1 centimeter in the HER2 positive disease, it will be prudent to give neoadjuvant, because you have something to alter your management post if they do not achieve a path CR. So for me, given a choice, and I've shifted practice, but only thing is that 70% of whom I counsel, they ultimately go up and get operated. But still we go on doing the neoadjuvant path. We will not be giving the benefit to these patients of altering a therapy in the adjuvant setting. So TNBC and HER2 for me should be offered neoadjuvant, because you have something to do if they do not achieve a path CR. Hormone positive, we can debate some other day. That's my take on it. So I have started to change. I lose some patients, but I think in 3-4 years, patients will understand that.
So, but the benefit of Catherine, that is adjuvant TDM1, was around 11% invasive disease survival, and that was complete group. So the benefit must be much lower in node negative and small tumor.
I totally agree, but that's the best evidence we have, and we can always look at the wrong points of our trial, but this is the best level evidence that we have. So, and my second point is, with all the data, if it is one of our family, will we not offer neoadjuvant? And what I'm going to lose, there's definitely no detrimental effect of neoadjuvant. I think that's my take. People may all differ. I agree to that. Catherine has the criticisms.
Yes, I also agree with Sahu sir, and the current NCCN guidelines also state that the neoadjuvant approach should be there in most of the HER2 positive and triple negative breast cancers.
Okay, so coming towards another part of the de-escalation strategies, it would be the duration of anti-HER2 treatment. So as we have seen with the standard 1-year trastuzumab, it has shown almost 40% reduction in the risk of relapse and 34 to 35% reduction in the risk of death per se. So now coming towards my panelist, Dr. Deepak. So what is your current practice, and will you be comfortable in using the short duration anti-HER2 therapy? If so, then what will be the particular subset of the patient, or you would like to use in all the patient, maybe considering particular the patient population as per the socioeconomic strata in our scenario?
Dr. Suhas, so if I refer to 2 meta-analyses published in last 3 years, one was from China, which was in favor of a longer duration of treatment, and another recently published in JAMA. The study was done in India only by TMH people, and that was showing that yes, shorter duration of treatment is non-inferior. So again, there are conflicting results, and we as of now don't have a clear-cut strategy. So to which patient we should offer a longer treatment or shorter treatment, or whether both are equal or not. So definitely I would like to give a longer treatment, 1 year of therapy. But however, if patient is non-affording, a very low risk, small size tumor, again node negative disease, then definitely at least 6 months, not lesser than that.
And so what is your take on 9 weeks of the treatment? Suppose the patient is not affordable per se.
Yes, again, shorter FINA trials, again, they were in favor. They were saying that it is non-inferior, but again, the margin of non-inferiority in the trial design was different across various trials. So it is currently very difficult to say whether 9 weeks will suffice or not. So at least 6 months of treatment should be there. I'm not
Okay.
comfortable with 9 weeks.
Okay. So, doctor,
sorry to interrupt. But
yes,
again, one point here to be noted that many times people use TCH regimen, or like Dana-Farber, we use only paclitaxel. So in that case, I think we should always give 1 year. So if you want to de-escalate, you should give anthracycline, whatever I think means. If you want to give 6 months, so that planning should be from day one. You should not give TCH followed by 6 months of trastuzumab. It should be AC taxane followed by 6 months of trastuzumab.
Yes, so anthracycline is serving as a poor man's trastuzumab. Yes, rightly said.
Yes.
exactly.
If I have seen people giving TCH and 6 months of trastuzumab, or paclitaxel trastuzumab and then 6 months of trastuzumab. So that should not be done.
So, as we have seen from the Persephone trial, that it has shown that was the only trial which has shown an almost a non-inferiority as compared to the other whatever conducted trials. So, but the main factor with the Persephone was almost 60% of the patients were node negative and 70% of the patients were ER positive. So, what do you like to consider these two factors, or maybe some other factors deciding the treatment plan? Suppose when the patient may not be affordable, or certain group of the patient where the cardiac toxicity will be main constraint per se for the use of the trastuzumab. Dr. Deepak. Dr. Deepak.
Yes, so mainly the size of the tumor, node negativity, and of course, if the patient has a cardiac issue, trastuzumab can still be given safely if the ejection fraction is within the normal range. But definitely, yes, if any point of time cardiac toxicity is an issue, then definitely I will cut short the duration.
Okay, and Dr. Samir? Dr. Bharat? Dr. Sahu, Sahu is there?
Yeah, I'm there. I'll just tell one thing.
So,
I totally, please, you wanted to ask something.
Yes, please.
No, I just have to, I totally agree with my co-panelist here. The only thing I feel that if someone cannot afford, but can afford 9 weeks of trastuzumab, I would give it, because no trastuzumab is definitely worse than 9 weeks of trastuzumab. So my point is, for affordable class, will you give 9 weeks? My answer is no. I would give even, I would not give 6 months also for anyone who has not received anthracycline. That's my also take. I believe there is a little bit of evidence to that in the subgroup analysis in the trial of the Persephone. But my point is, for patients in India who cannot afford trastuzumab or have a budget of around 1 lakh, do not hesitate to give even that 9 weeks, because it is better than no trastuzumab at all. So that is how I take it. But someone who has not received anthracyclines, rightly put TCH or APT regimen, I would give 1 year of trastuzumab. I would not otherwise give. I will otherwise give a better chemotherapy. I would not de-escalate chemotherapy in that sense.
Exactly. So now I would like to ask each and every panelist, including Dr. Sahu. So as we have seen from the short her trial, that is tumor infiltrating lymphocyte was one of the factors that was taken into the consideration. And since it was seen that those with the high TIL has better outcome. So whether every panelist from our this discussion, whether would agree or whether they take into consideration this factor while deciding the treatment plan for anti-HER2 treatment, the duration of the treatment.
Not as of now, but yes, definitely the evidence is evolving, and we would like to see some more trials for this prior to a definite conclusion.
Hello. Hello.
Yes, I think I agree with the other co-panelists. I also would not alter at this point of time. I'll wait for something as a robust prospective randomized trial on this setting to do change this, because adjuvant chemotherapies and target therapies cure patients. I would not just do it with a small analysis. I would probably wait. And at this point, I do not consider this into my schema of things when I plan my therapy.
But do pathologists report TIL? That is the issue. So do they
Yes.
report TL? I think whether it is
The
standardized,
day,
whether we
Samir,
can
I
rely
feel
on
that day, Samir, I feel the day it comes into how we take the treatment into consideration, we will force them to do that. I think.
But whether
Exactly.
that will be again standardized, whether we can rely on pathologists not trained in reporting that. So that all issues will be there, sir.
Samir, just think of 3 years back how targeted therapies, the reporting of the NGS, and things are changing. Na? Once the things
Right.
come into something, then
Slowly it may change.
they also will change. I feel we have to give it to them. For me, learning the new drugs names takes me a lot of time. So everything takes time. I think so.
Right.
And the last question now, Dr. Sahu, with the de-escalation strategies, is there will be any subset of the patient you will look out for the chemotherapy-free regimen for HER2 positive early breast cancer?
I will probably use the trial of a dual HER2 if the patient is very, very apprehensive for a chemotherapy. If the new adjuvant pertuzumab plus the trastuzumab do achieve a path here, although the percentage are much lower than addition of taxanes, and if they do achieve a path here, why do you want to add chemotherapy? You can just go ahead and give adjuvant dual target therapy itself. So that would be my segment where I really would not consider chemotherapy. Otherwise, if given a chance, I will at least add a weekly paclitaxel. Let the other panelists decide, because that's something very interesting.
Yes, so I think Dr. Suhas is referring to Fergain trial, in which the response was made based on a PET-CT evaluation after 2 cycles of pertuzumab and trastuzumab. So patient who have received CR after 2, if I am not wrong, CR or some response after 2 cycles, so they were allowed to continue with only pertuzumab and trastuzumab. So I think still the evidence is small, but yes, it's encouraging. So in near future, it can come up as a strategy.
So I would like to give an example of a patient over here. I'm having currently with the almost 60 years old lady who is having a CKD with creatinine of 5.4. She's having a locally advanced breast cancer, which is a triple positive. And now with the paclitaxel also some cases worsening the nephropathy. So I think this would be a particular patient, whether we would like to use only with the maybe the either single or dual HER2 blockade and avoiding the chemotherapy. I hope my panelists
this is in the neoadjuvant setting.
Yes, neoadjuvant.
Yeah. So you give a, that's what I told you. If you give a dual target therapy and the patient does not achieve a path CR, then will you add a adjuvant chemotherapy?
Right.
And so you will, because that's what it is.
Yes.
So the point is that the 30% of patients do achieve a path CR with the dual targeted, if I'm not wrong. That's the data. And then you can get away without chemotherapy. But if they do not, you have to resort to chemotherapy at some point.
Exactly. So I would agree with everyone, including Dr. Sahu and other my panelists. So I would like to conclude.
One more question to Sahu, sir. Sir, I have seen patient receiving neoadjuvant paclitaxel trastuzumab. They go in patch CR and people don't give anthracycline on. That means they don't give any chemo. They just give radiotherapy and start maintenance trastuzumab. So what do you think? Means in such cases, if the patient has received only taxane trastuzumab as a neoadjuvant, but patient has achieved patch CR, so whether you will not give AC as an adjuvant or whether you will give.
फिर से समीर बोल, मैं टेंशन हो गया, मैं उल्लास को देखा स्क्रीन पे तो I am tensed up. फिर से बोल.
Sir, if a patient has received taxane trastuzumab as a neoadjuvant, only taxane trastuzumab, no pertuzumab, okay? And patient went in patch CR, which is the usual, means now pertuzumab hardly any patient take. So for usual routine practice, a patient has received taxane trastuzumab 12 weeks weekly, and patient underwent a surgery, patient pathological is patch CR. So whether you will give adjuvant AC 4 cycle or you will just continue with maintenance trastuzumab.
So I think I don't have evidence for that, but I will take my chance, probably give a consent, and I will go ahead with and complete 9 months of trastuzumab. That's probably what I will be inking towards, but I will take a good consent so that I am not sued at a later point.
So basically, AC should be given even if the patient is in CR. After
I understand. The take home is path CR, but if you don't have a data, you cannot put it across. And I think Ullas will agree that data is so very important. And if it is not there, all of us know path CR, we probably have that. We have trials to tell us that we can go about without chemotherapy, but it was a dual HER2. It was not single. But I will still take the chance, but I'll take a good consent. That's what it is.
Can I come on that? I have 2 questions to ask to Dr. Sahu. With the permission of the chair, can I ask?
Yes, please.
सर एक तो क्वेश्चन ये कि आपको इतना सब कुछ कैसे आता है, मतलब हमें छोटा सा करने पे सब कुछ नहीं आता है, आप इतना सब कुछ कैसे करते हो? पहले ये बताओ, दिन में कितने घंटे पढ़ते हो?
ओके उल्लास,
वेरी नाइस क्वेश्चन।
क्या है कि तुम लोग बड़े बड़ी जगहों पे बैठे हो जहाँ करोड़ों कमा रहे हो और बहुत पेशेंट्स हैं, तो हम लोग क्या छोटी जगहों पे बैठे हैं, फ्री का बैठे हुए हैं, तो पढ़ना पड़ता है। और सेकंड चीज है, दिल्ली और बॉम्बे में कुछ भी बोल दो वो सही है, भोपाल में सब कुछ पढ़ के बोलना पड़ता है। आगे बोलो।
ओके, द नेक्स्ट क्वेश्चन इज सर, करोलरी सो करोलरी कौन बोला है? विकास, वेरी गुड आंसर, बताता हूं तुम्हें विकास। Yeah. So just a corollary to that, you said 12 cycles of weekly Paclitaxel and trastuzumab, patient achieves a PCR, you will not give.
No, I told I will give the option to the patient.
Fair enough. My question is, somebody has taken 3 cycles of TCH and has got a surgery done and has got a PCR. Will you go ahead and give the remaining 3 cycles or not?
I will, because I have not completed my scheduled therapy.
मेरे ख्याल से भी अगर 12 साइकिल पैक्ली एंड ट्रास्टुज़ुमाब दिया है तो we should give 4 cycles of AC and then probably maintain the
I would not, because I have my paclitaxel has been given very adequately. I have completed my 12 doses of paclitaxel.
But AC नहीं दिया ना sir?
I totally agree, but TCH, but there is good enough schedules of a weekly pacli of 12 weeks. The only thing is we did not have pertuzumab. I know what you're coming to, that if you have not completed your so-called therapies, why would you just take away? And you have a point. I totally take your.
Sir, are you giving paclitaxel with trastuzumab or single paclitaxel for 12 weeks?
No, with trastuzumab was the question.
So how will you incorporate AC then? You have to discontinue trastuzumab.
Yeah, we will.
So that is again, you have to again reload the patient. That will be a failed strategy.
So the one protocol is 4 AC, 12 TH, and then H. No, I mean almost same protocol.
But you are using AC, then you are continuing trastuzumab. You are not interrupting.
I have not given. Somebody else has given. I'm just giving an opinion.
Yes. No, so according to me, that is a failed strategy.
Fair enough.
So, sir, basically, maybe better to just give complete neoadjuvant AC also in
let us give the panel. They have to complete the full program. Yeah.
Okay.
Yeah.
I am only next on program.
So you can, Dr. Batra, you can carry forward from here.
Okay, let me carry forward from here. So that is what happens when I and Dr. Sahu come together on a panel, and I really hope Dr. Sahu itching to have a debate with you, on a real face-to-face platform, and enough of these virtual things.
Dr. Ullas, may I request Dr. Akash Tiwari to invite the chairpersons also?
Sure.
Hi, for this session on lung cancer, I like to invite Dr. Rajiv Das, Dr. Nagaraj, and Dr. Sumant to chair the session and call the next speaker. Thank you.
I am the speaker.
उल्लास सर, 3 लोग बीच में, उल्लास सर इनवाइट करने का मौका तो दे दो, गैप फिलर बैठे हैं 3 चेयरपर्सन.
Sir, I don't deserve any invitation. No, that is a problem.
I know.
Go ahead, Sumant.
Yeah, please go ahead.
Nagesh sir, please do the honors, sir. You are the senior most. Sir, please do the honors.
It's a good evening, and we come to the next session. So it's a pleasure to introduce Dr. Ullas Patra, and I've been listening to him earlier as well. And he's going to talk about role of Nivolumab in NSCLC and Indian perspective. And I'm sure that's going to be very, very interesting, because I do see a lot of attraction for this particular molecule. Over to you.
Thank you, sir. And going ahead and on a very serious note, the role of Nivolumab in second-line non-small cell lung cancer and Indian perspective. And my first reactions when I first saw this topic about Nivolumab in second-line non-small cell lung cancer was, ye to ho gaya tha na? I mean, this was done and dusted. We all thought 5 years back it has all been taken care of. So what's new in this really? And my subsequent reactions on this was that we are talking about an Indian perspective. So I have kept my talk into 2 parts. One is I will show you the data of Nivolumab in non-small cell lung cancer, and then I will show you our data, the Indian perspective of Nivolumab in whatever 65 odd patients that we have used. So let's start from the beginning about the second line non-small cell lung cancer. We are talking about an era which is much prior to the COVID era. And let's start off the history of lung cancer treatment. Initially, we started off saying, 1970s, we started off saying, some treatment is better than best supportive care. Now in this, please look at the difference in the graph, the difference in the curves between the best supportive care and chemotherapy, you had probably overall survival of around 6 to 8 months. Then came this landmark study, the ECOG 159 study, in which was the Plateau Trial, which basically said that whether you give Paclitaxel or Gemcis or Docetaxel or Paclitaxel, by and large, everything is going to be the same. You have a 1 year overall survival of 33%. The median overall survival of a lung cancer first line is 7.9 months. Please remember this, and please look at this tail of the tail, which we really call it. Overall survival of 7.9 months, and look at the way the tail is falling down over there. This was the landmark trial, and I hope Eli Lilly is not listening to this. This was the pemetrexed platinum versus gemcitabine platinum based on the histology. 2009. This was the trial which changed off the entire basis of lung cancer treatment. Look at the difference that you have in non-squamous. 1 month. 1 month was the difference between if you give PEMCIS and GEMCIS. You have an absolutely it was survival of around 1.2 months between the two, but this was the trial which actually led to a fantastic change in the management of lung cancer. And today, if you actually look at this, I'm actually remember about Shakespeare, who said, was it much ado about nothing? 1 month. Today, I'm going to show you some graphs which are going to be fantastic, and 1 month actually was nothing. Now, let's look at the second line treatment. The approved second line treatment agents were basically 3. You have 1, docetaxel. Second, you have a pemetrexed, which was an adenocarcinoma, and the third was a new or an old drug called as TLC. TLC is not a new drug, which was basically tender love and care. That is what most of our patients used to actually get. Now let's look at docetaxel in second line non-small cell lung cancer. Since I'm going to talk about non-small cell lung cancer, this was a randomized controlled trial of docetaxel versus best supportive care. Now look at this. The final conclusion of the abstract is treatment with docetaxel is associated with significant proportion of survival. The benefits of docetaxel outweigh the risk, and this is where you feel, yes, docetaxel is a fantastic drug. But then read in between the lines. What happened? 6 patients, kul milake 6 patients, 7.1% patient responded. The time to progression was 10.6 versus 6.7 weeks. Median survival was 7 months versus 4.6 months, and that is where docetaxel was the standard of care, and which was really not a great thing to get acknowledged upon actually. So let's look at the other agent. We all looked at docetaxel. Now let's look at pemetrexed. And this was the pemetrexed trial which basically compared. So dosi was compared with best supportive care. Pemetrexed was compared with docetaxel. Now what happens over here? Pemetrexed was not better than docetaxel. Pemetrexed was equivalent to docetaxel with an absolutely fewer side effects, and that is how it basically got approved in the second line treatment of non-small cell lung cancer. Response rate of 7%, median overall survival of 7 months, and that is where we actually basically had got. So to summarize, the treatment of stage 4 non-small cell lung cancer was like this with a dark clouds, and this is not the Delhi picture today. Delhi has got all smog. This was lung cancer. And this is, however, slowly but surely the things began to change. And it began to change in the year 2014 when you had the immunotherapy was discovered. It came in Science, it came in Nature, it came in NAGM. NAGM, Nivolumab. So docetaxel is now our standard of care. Nivolumab was compared to docetaxel in 2 trials. One was Checkmate 17, one was Checkmate 57. And this is what it basically shows, that Nivolumab was better than docetaxel. Look at the graphs differences now. Median overall survival of 9.2 versus 6 months, but that is not something which is important. Even in the Checkmate 57, you have a 12.2 versus 9.4 months. Mind it, it is not a PFS advantage, it is an OS advantage that you see with Nivolumab versus docetaxel. Now, these were the updated results in 2016. What was beginning to get interesting was that people who responded had a good response. So here you have, remember, we had a 1 year overall survival of 33% starting from the first line. Now you have a 2 year overall survival of Checkmate 17 in 23% versus 15%, 29 versus 13 in the adenocarcinoma. So this was beginning to get actually better. The tail of the tail was getting better. But we are medical oncologists, we are greedy. Sometimes when we have more, we want de-escalation. When we have less, we want more. So we wanted more, and we said we will mange more. So this was the data of Nivolumab versus docetaxel, a 5-year long survival data, which was presented in ACR. And my first reaction, the long-term survival in non-small cell lung cancer was, is this a joke? Non-small cell lung cancer, come on. I mean, there is no long-term survival over there. And people must be kidding. So what BMS did was they had 4 studies, Checkmate 3, Checkmate 63, Checkmate 17, Checkmate 57. They took up all these studies and had a 4-year survival data. And this is what they found. Now we are looking at an OS survival and we are looking at a 4-year survival of 14%. Mind it, remember, you had 1 year survival of 23% from the first line. And from the second line, you have a 4-year survival of 14%. That basically meant that people who were responding to treatment are the ones who are continuing to respond to the treatment. This is what I am distinctly remembered of Dr. Senthil Rajappa whenever I show this diagram, which is the tail of the tail, which we honestly call as. Now look at that was all 4 trials. This is OS with Nivolumab versus docetaxel. And you have both the trial 11.1 versus 8 months. Again, you have a 14% advantage of Nivolumab in the second line versus only 5% in the docetaxel arm. Now let's look at the PDL1 expression. Remember, I am talking about the second line treatment. If you have PDL1 less than 1, you have 9%. If you have PDL1 positive, you have 20%. So yes, higher PDL1 in second line does respond better, but it is not that the lower PDL1 does not respond. Obviously, if you have a higher PDL1, your chances of response are much more higher. Now let's look at, can we predict that which of the people are going to do better? So what they did was, they said, okay, fine, let's start Nivolumab. Let's have an analysis of this Nivolumab at 6 months. People who had a CR or a PR at 6 months were 58% likely to live for 4 years. And people who had stable disease was 19% and this was 4%. Compare this with a docetaxel arm. So again, if you have a person who is responding to the treatment in the first 6 months, he is more likely to get to respond. This is an OS from the time of response with Nivolumab versus docetaxel. And this is almost the difference in the gap in the knowledge and the salary that Dr. Sahu and I have. Sahu obviously being the Nivolumab and I being the docetaxel over here. And there's definitely a jump which I've never been able to compete. Safety summary, by and large, all the drug is very well tolerable. We have got great experience, as Dr. Nagaraj said. We have got great experience with this drug and there should not be an issue with this. So what did we learn from these trials? I'm just going to give you some take-home points basically. Number 1, do not look at the PFS when you look at the immunotherapy. Look at the overall survival effect because that is stronger than the PFS. Second, the tail of the tail. You had to have there are 20% of people who will respond, but those are the people who will respond very, very well. Adverse effect, absolutely well tolerable drugs. There is nothing that you can, 5% of people will get some autoimmune complication, but as we are beginning to get more and more used to it, side effects are very, very, very well manageable. And the quality of life is absolutely fantastic. So that was about Nivolumab and second line non-small cell lung cancer. And that finishes my first side of the topic of the talk. And this is something for the next 4 to 5 minutes, I'm going to present you our data about the real world data. Now, this is what, we all want to look at it across, but this is actually the real us. So let's look at the Indian perspective. Let's look at our data, which we have given in RGCI over the last 5 years of Nivolumab only in lung cancer. Started from 2016 to 2021, we had 65 patients basically. Now, this data was collected in March 2021. That is why the number of patients were a bit less in 2021. The median age, which we can see over here, is 62 years. We had more males and lesser females. The PDL1 status, we had more people who had PDL1 negative. PDL more than 50% was only in 14. Squamous were more than non-squamous. Very importantly, pleural effusion was present in 30. ECOG PS, we had taken only those patients who are responding, who have a better PS, ECOG PS 1 and 2. Extrathoracic mets were present in 45. And liver and brain mets basically were present over here. Now, this is if Sahu is still there and is looking at this. The median time to start of immunotherapy was basically 9.2 months. So that is what we usually waited in the early years to start immunotherapy, which I think is a flawed statement. We should now start immunotherapy as early as possible. The prior lines of systemic treatment were 1 in 40 and 2 in 25. Number of IO cycles given are the median number of cycles are basically 4. The best response to immunotherapy, whether it's a SD, PR, SR, is 25. We had a progressive disease on IUPD in 40 out of 65 patients. Now, these are the data. This is the swimmer's plot basically, which shows. Now, this is all the patients, and this is basically patients with PDL1 less than 1, 1 to 50, more than 50. Now, what I would like to show you is that these results are absolutely concordant. You have some patients who are actually going to be long-term survivors. In second line, you cannot actually differentiate whether they have got PD-L1 more than 50%, 1 to 50%, or less than 1%. This was the median overall survival. Our overall survival PFS was 3.2 and the OS was 7.4 months. Very, very important. OS by histology, our squamous cell, non-squamous cell did better. Performance status was the single most important factor. People who had a good ECOG PS did much better. People who did not have an extrathoracic disease did better. People who did not have an oral, have a pleural effusion did better. Then higher the number of extrathoracic mets, people did worse. OS by PDL1 was better technically in 28.1 months, but it was statistically not significant because of the less number of patients. But again, the statement over here is that people will respond to immunotherapy in second line irrespective of PDL1. But if you have a higher PDL1, the chances of response are much more higher. Liver mets, if you don't have liver mets, that is better. OS by the number of cycles, basically people who got more cycles were obviously more likely to get better. Now, these are my last two slides, very, very important. Now, this is the Checkmate 17 trial, which was in the squamous cell. And this is what the results were there in the trial. You have Nivolumab, you have docetaxel. We tried to extrapolate and superimpose our results. We are in the red. Our results in squamous were lesser than what we saw in Checkmate 17. The red being, red being the Nivolumab and our this thing. But the docetaxel also did not do that better. But if you look at the Checkmate 57 design, this was Nivolumab, this was docetaxel, and we were bang over there with Nivolumab. So adenocarcinomas, our results were absolutely in sync with the data which has been presented before at the Checkmate 57. So with this, I would definitely like to conclude that there is hope in lung cancer. Hope is there in first line, and definitely even in second line, there is a lot of hope. And this is the Lung Cancer Awareness Month. And I would like to conclude by saying lung cancer deserves a cure too. And the moment I made my last slide, I saw Amish Vora coming, and now I am having butterflies in my stomach, and my palpitations are high that he'll ask me questions. So before he does that, thank you, and I'll be happy to take any questions. Thank you.
Thank you, Dr. Ulas. A very concise presentation. I think a couple of questions should be good, if the program allows that.
I have to ask Ullas a question.
Yes, yeah, please go ahead. How are you, Amish?
I'm fine, sir. How are you?
Good, good, good. Please go ahead. Yes.
Ullas, some points about hyperprogression. I'm sorry, you were going so well and so fast that my brain gray cells were not able to adapt. So I thought, let me be a stupid student and ask a question. Hyperprogression in non-small cell. What is your take on that?
So we had 3 to 4 patients in 65 who had hyperprogression. All of them came in a crop. So yes, it is a reality. It does happen. 3 to 4 patients of hyperprogression. The second question obviously is going to be pseudo progression.
No. Pseudo progression not. In hyperprogression, when did you notice that there is a
first
clinical
cycle onwards? First cycle. If hyperprogression has to occur, it will occur in our case, it occurred in the first cycle. The second thing is, now we have become far more intelligent in selecting our patients. I always ask this question to my patients that if you can ever afford immunotherapy, take it as early as possible. Don't wait it for the third, fourth line. It will not act. The earlier you give, the better it is.
Do you believe hyperprogression gets abolished the moment you combine IO with chemo?
Yes, it does. Yes, it does. Yes, it does. Because chemotherapy does take care of those initial 1 and 2 cycles that we give. Yes, it does. Okay. But in second line, there is no approval of Nivo plus chemotherapy, so you will not be able to see. But in first line immuno plus chemo, when we give, we hardly see any hyperprogression.
Thank you.
So we move on to the next panel discussion, I'm sure. Hello. Yeah, Amish.
We can hear you. Yes.
Yeah, please take over, Amish.
Okay, thank you so much. In brochure, I was seeing my photograph along with Ullas's photograph, and I was so happy. Wow, with the legend, someone's photograph is there. With that, we have 20 minutes to discuss.
So that legend was Amish.
Okay, you, Amish. I accept it, no issues. So in 20 minutes, I understand my slide is visible.
Yes, yes.
Yes, sir.
Okay. Okay. So Dr. Indu Ambulkar is there, Dr. Shruti Kate is there, Dr. Akash Tiwari, Dr. Nilesh Lokeshwar, and Dr. Vivek Agarwala. Am I right? Okay. Nobody
Right, sir.
says yes, so I
Yes,
understand that these
Amish,
many
I'm
people.
here.
Yes, Nilesh, I can see your face. Okay. So Nilesh, let me start first with you only. No panel, no presentation is complete without NCCN. And this is today morning I have taken. So I was just little wondering if you see in this, in adenocarcinoma, EGFR and ALK are the only category 1 recommendation, while all other 6 and PDL, all other 6 are category 2A. And in squamous, there is, except for PDL1, there is no other category 1 recommendation. So Nilesh, do you do EGFR, ALK and PDL1 in all your patients, or all 8 mutations plus PDL1 upfront to begin with, if the moment metastatic adenoCA is there?
So I would like to do all 8 mutations, preferably even in NGS plus PDL1 in all my patients. But at a practical level, in many of my patients, I would probably do the EGFR, ALK, PDL1, ROS1, as well as the BRAF and HER2. This is what I practically do.
Okay, okay. So MET and RET you give for the later stage.
Correct. If these are negative, then I process it further.
But there is a discussion where if you have a RAS mutation positive, which is almost in 22 to 24% of patients, they're completely exclusive of other mutations. So should we not start with just RAS mutation? What do you say?
Yes, we should. And now there is a targeted drug available also, though not here, but I've not been doing it regularly.
Dr. Shruti, what is your take on that? Do we have Dr. Shruti here? Dr. Indu?
Yes, sir. Sorry, I didn't get the question.
Dr. Shruti, so, let's not go into the controversy. Let's come to the point of ALK and RAS, because we have very little time. In your practice, Dr. Shruti, when you see ALK positive patients, do you rely on IHC, FISH, NGS, or any of these 3 or all 3?
Sir, the concordance of IHC and NGS is the highest. So I don't verify it by doing a FISH or anything. The concordance is highest for IHC and NGS. So I would, what we do is we
If
have
IHC is positive, do you go forward with FISH or NGS, or you take it as positive?
I take it as positive, sir.
You take it as positive. Dr. Vivek Agarwala. Dr. Vivek, are you there? Okay. Dr. Indu? I was told that these people were there. Dr. Ullas, have you disappeared or you are still there?
Sir, I guess Dr. Ullas is not there. Dr. Vivek Agarwala is there. Dr. Indu Ambulkar, they both have joined.
But I can't hear Dr. Vivek. Dr. Vivek?
So, Dr. Vivek, you are not joined with the audio.
Dr. Akash also I see, but I have not seen. I don't know. Dr. Akash, yes.
Yes, sir.
Dr. Akash, if IHC is strongly positive, do you need FISH or NGS?
No, sir. In a case where IHC has been done first and it is positive, I go ahead with therapy.
Then go ahead with this.
With therapy.
Dr. Bharat, a patient of NSCLC comes to you in the morning with the tissue block and IHC in the evening comes positive. Would you even bother about doing other mutations? Dr. Bharat Chauhan.
Yeah, you're saying IHC in the morning?
If you do immunohistochemistry of ALK and in the evening it comes positive or the next day it comes positive, would you bother to go ahead and do any NGS for any other activating mutations, or you would take it as ALK positive and go ahead?
I will take it as ALK positive and go ahead.
Okay.
That is what I will do.
Right. Dr. Vivek Agarwala, have you joined? Dr. Indu, I can see your name.
Yeah, Dr. Amish, can you hear me?
Yeah, I can hear you, Dr. Indu. So, Dr. Indu, the next question to you is that would you look for any variants in fusion partners? Like ALK EML4 is there, but there are other variants also.
Yeah. So I would like to see the other fusion partners also, because at some point of time the patient is, likely to develop resistance to the given line of treatment. So if there is the feasibility of the testing available to look for the variant, I would like to go for it.
You would like to go for it. Dr. Nilesh, in the table which I have shown, in EML4 ALK version 3, V3, variant 3, if you see the brigatinib, overall response rate is much high compared to others. Does this make in practice any sense, or we are still far away from this?
So, Amish, there are 2 points. One is that we know that patients who have the EML ALK V3 type of a variant generally do not do well with the first generation ALK inhibitors. Having said that, the challenge with these, detecting them is an issue because they cannot be picked up in many of the DNA-based NGS platforms that we have.
Correct.
So either you do a dedicated RT-PCR or you go for RNA NGS or you do ctDNA, which is something I think at the current point of time, most of us are not doing it. But sometimes if you have a patient who's got extensive, aggressive clinical phenotype, and if finances and resources are not an issue, I'd like to do that because this subtype, the hallmark is that it's a very aggressive disease, very unlike most of the other ALKs to come in your clinic.
Okay, right. So the overall response rate and progression-free survival with the second and the third generation tyrosine kinase inhibitor is much higher when there is a variation in EML4 ALK. And if the test allows us, we all should do it. And absolutely rightly told by Dr. Nilesh, RNA-based NGS would help. Coming to the very important question for today, Dr. Indu, as you can see in this NCCN guidelines, alectinib, brigatinib, lorlatinib, ceritinib, and crizotinib all are category 1. If finances is not an issue, I again repeat, let's not talk about finances. And if the drug acquiring is not an issue, what would be your choice amongst these 5 category 1? Indu?
Can you hear me?
Yeah.
Okay. So, as we are aware that ALK positive lung cancer, they are likely to develop brain metastasis in due course of time. Like most of the time we see that, and that has been shown in the studies with crizotinib also. Like crizotinib usually doesn't work in CNS disease. So my first choice would be if the availability is not the issue, then maybe brigatinib or lorlatinib. Alectinib is also a good drug with the good CNS penetration. So actually all the 3 options are fine, like alectinib, brigatinib, lorlatinib.
Okay. Dr. Shruti, I saw you nodding your head regularly. What would be your choice? Very, very VIP. I'm sure you're treating a lot of VIP patients. Very, very VIP patient. Money is not an issue. Drug is not an issue. What would you select?
Sir, I would agree with madam that first choice should be the best choice, and I would offer as of now with the data of the Crown study, I would prefer lorlatinib, and if not, then brigatinib or alectinib. So I would just use the best agent. As of now, we have data or in the form of hazard ratios, and which are most impressive for lorlatinib. And I would just pray that by the time he or she progresses, I have something else. So
okay, that something else is a question mark today. If you start with lorlatinib, Dr. Akash, do you agree with Dr. Shruti and Dr. Indu that your brigatinib or lorlatinib should be the first? Yes, Akash.
So, sir, in a first line setting, in my personal preference, I'll use a drug which has lesser side effect, chances of more compliance, and which we have more data and experience with. So, if resource is not a constraint, use alectinib. If it is a constraint, use ceritinib. So, alectinib would be my choice.
Excellent, Akash. So you agree that alectinib is the most tolerated TKI in ALK positive armamentarium.
Yes.
Okay, excellent. Nilesh, coming back to you. Profile 1014, they have shown a very nice survival graph. If you have used crizotinib, and if you have an option of using second line and third line tyrosine kinase inhibitor, your median overall survival reaches almost 89 months. And 5-year overall survival crosses 75%. Then why are we looking at second and third generation when we have such a data of 6-7 years follow-up? Nilesh.
So, if you look at it in all the trials which are there have all compared their studies with the first generation drug. Right. Having said that, sequential is inferior to second generation and third generation period.
In terms of PFS or OS, Nilesh?
In terms of PFS and OS, in both terms.
Okay.
And now the hazard ratio is a matter of debate because everybody has used an extremely inferior comparator to get such brilliant hazard ratios, and there's no doubt about it. So coming back to your question, I would decide my treatment based on the presence of CNS disease or no disease, a drug that will cover significant resistant mutations and the side effect profile. A standard sequence would be to use alectinib, go on to brigatinib, or vice versa if there is significant brain metastasis to start with. That's how I would start, and I would reserve lorlatinib for a second line because that is number one when you have more mutations coming up. Number two, lorlatinib is the only drug that covers almost all the mutations, and number three, it has better CNS penetration in the resistant setting.
Okay, right. So, this is the hazard ratio which people keep talking about in all the trials. Dr. Shruti was talking of hazard ratio. That way, lorlatinib should be given upfront to all patients, Dr. Shruti. Hazard ratio of 0.21 and 0.28 compared to if you see.
Yes.
Yeah,
that's what there's no match actually, but I agree with Dr. Nilesh. See, comparing sequential treatment vis-a-vis, all these are cross-trial comparisons, so we cannot be sure that sequential treatment in this patient vis-a-vis second, third generation TKI treatment in that patient would that have made a difference? That would only be sorted out if these are the two comparative arms. So unless and until they compare it with the second, third generation, it's hard to say. But just if you look at statistics, so this appears to be the best drug.
Okay, Dr. Akash, PFS of, we have alectinib data. PFS of alectinib is 34.8 months versus 10.9 months of crizotinib. But if you combine first line PFS of crizotinib of 10.9 months and a second line of alectinib, addition of both is when you use alectinib for first line. So do you think that either alectinib or lorlatinib in today 2021 makes more sense?
In terms of first line, sir? So I think a lot of these sequential data assumes that a patient who has received a first line would go on to receive a second line.
Correct, absolutely right.
And I think that in this transition between first and second line, leave out the trial scenario. In real life scenario, there are a lot of loss to follow-ups. And I think if we combine that data, the outcomes would be very poor. And therefore, a drug which has a longer PFS, more tolerable, I think in a real life scenario will give us better outcomes as compared to a
excellent
drug that has longer PFS in
point.
Study with more toxicity, or that has a shorter PFS combined with another drug has a longer survival.
Great, Akash. I completely agree with you. Vivek, I see you now joining.
Yes, sir.
Vivek, would you use best drug first or sequential treatment?
Sir, I think there is a discussion whether what is the best drug, whether you are referring to brigatinib, or you are referring to
So I'm giving you
lorlatinib?
two scenarios, Vivek. 45-year-old female metastatic non-small cell IHC positive IL confirmed by FISH. There are no brain mets. Just a rapid fire answer. What would be your first line treatment?
I'll go with alectinib, and
You'll go with alectinib.
Yes, sir, and I'll reserve lorlatinib for later.
You will reserve lorlatinib. Vivek, stay there. This is what the ESMO 2020 forest plot chart for lorlatinib as compared to brigatinib. If you do not have brain mets, you know, the hazard ratio almost touches 0.26 or 27. And if you do not have brain mets, lorlatinib, you see the ratio intracranial time to progression is almost 100% to the 25 months of follow-up. Why do you want to use alectinib when such a nice data with lorlatinib is there?
Sir, alectinib also does work similar way, and if you look at the median PFS between lorlatinib and alectinib, it is in fact alectinib which actually has a better PFS as compared to, and you can't compare.
Here, the last PFS had not even median PFS not even been reported.
Yeah, so the same is with alectinib also. Both are
the
not
latest. It is 34.8 years. ASCO, ASCO abstract LX trial. They have reported.
Yeah, sir, but you have to look at the tolerance also, sir. The
You're
alectinib
absolutely
is a
right.
very, very
Alectinib
safe
is more
drug,
well tolerated than lorlatinib.
much better tolerated, and when there is progression on TKI, I think lorlatinib does work in those patients who have progressed on alectinib. But if the patient progresses on lorlatinib, I don't think that there is any
What do
data
we
of
do?
any
What do
TKI
we
that
do?
works.
Sir, I have a question actually.
Yes, please.
Sir, when we are talking about the tolerance of lorlatinib here, I have used lorlatinib after progression on ceritinib, and the tolerance was extremely poor. So my feeling is that the tolerance in a place where the patient has progressed is bound to be even lower as compared to the upfront setting when the patient is actually in a better fit general condition. So I mean, that debate will not get over, but tolerance is an issue even when you use it in the second line or the third line setting.
Correct. You are
But
right.
sir, alectinib is such a
Alectinib is a very well tolerated drug.
beautiful
No, but
drug, sir.
what
The
Dr.
patient
Shruti was
doesn't have any
mentioning
side
was that alectinib followed by lorlatinib, probably the side effect profile may be higher compared to lorlatinib used first line or the earlier lines. That is, and I get your point. Nilesh, you have to give the final point. You were talking of overall survival. What I get, all the panelists want to use basically an alectinib or lorlatinib as early as possible, maybe the first line in ALK positive. Nobody wants to use crizotinib right now if other drugs are available. In a resource constraint, I think ceritinib is something which people have said that they would use. If you use ceritinib, then followed by lorlatinib, or if you use any second generation TKI followed by lorlatinib, makes more sense today. So this is what we have got. Please talk about overall survival, Nilesh. You were talking of overall survival. I was a little confused there. And then we can move on to BRAF quickly in next 2 minutes and wind up the panel.
So I'm sorry, what is your question?
Overall survival with this second and third generation TKI, as compared to crizotinib or as compared to, even crizotinib or chemotherapy. Yeah.
So chemotherapy versus crizotinib barely just about has any OS advantage. In fact, there is hardly any advantage.
Correct.
Alectinib versus crizotinib, brigatinib versus crizotinib, lorlatinib versus crizotinib, there is an excellent survival advantage. But none of the second or third generations have been compared to each other. So we don't have that question answer.
Right. So, Nilesh, in your practice, would you agree that you would use alectinib followed by lorlatinib? That is what I got. That is what I get from majority of the panelists.
So that is correct. But I'll tell you, that's not what happens in practice, because there are other implications like the access programs and things like that that come in the picture. And typically, a lot of my patients have followed that route of using ceritinib, followed by alectinib, then a brigatinib or lorlatinib, and a subsequent therapy after that.
Okay, I get your point. So the verdict is not confirmed, but I think if drug is not an issue, then alectinib followed by lorlatinib or ceritinib followed by lorlatinib makes sense. That is what I get from everyone. Akash, quickly, last 2-3 questions about BRAF. Are there any clinical characteristics when you will ask for BRAF mutation upfront, first day of the patient? And if yes, would you go for NGS or would you go for RT-PCR?
So, sir, currently in my practice, because once we are using the sequential EGFR AL cross, we used to exhaust tissues. We are doing all these limited NGS panels for lung, especially with the coupons available. So we are doing it all patients upfront, and we are using NGS because of this reason, that the tissue does not become an issue subsequently.
So Akash, you apart from NGS coupons, you won't ask for IHC or FISH for ALK?
No, sir.
You don't ask for IHC or FISH for ALK. Vivek, do you do the same thing?
If I'm doing an NGS, sir, then usually I don't do IHC, that is mistake. And if I'm doing IHC in those patients, then I usually reserve the NGS for later lines when the patient runs out of other treatment options. These are resource constrained patients where we want to do just PCR, EGFR, PCR, and IHC for ALK, ROS.
Okay. Dr. Shruti, would you do the same thing, NGS, but no IHC for ALK? Dr. Shruti, Dr. Indu, do you do the same in your practice? Indu, you will have to unmute yourself. I see Dr. Shruti also, but...
Yes, sir. Yes, sir. So I do an NGS.
We can't hear you, Dr. Shruti.
Sir, I do an NGS for these patients, sir.
Okay. So Nilesh, you also follow the same? No IHC, only NGS?
I do an NGS, but after sending for the ALK and PDL1.
After sending for ALK and PDL1. That is what normally we all follow, ALK and PDL1 by IHC and then give NGS. ALK, nowadays IHC reports are available in just 1.5 to 2 days time flat. So I, reserve my NGS for just 2 days more rather than sending everything upfront. That is what I do. Dr. Indu, you are there. Dr. Indu? Okay, Dr. Vivek, if BRAF positive by say NGS comes, BRAF V600E, the standard garden variety BRAF mutation, what is your first line choice?
So I do counsel my patients for a combination of dabrafenib plus trametinib.
Okay.
And that is my desirable treatment options.
That is your desirable. Dr. Akash, same as Dr. Vivek?
Yes, sir. First line treatment option, a combination of TK. And sir, I'd like to add the reason that we do not do a IHC before NGS is that from Indore, we have to send it to Delhi for the same test. And the TAT there is almost 7 days.
Okay,
so
I get your point. I get your point. Perfect. If you do an IHC by ALK on a US FDA defined platform, the guidelines clearly mention that you don't need to go anything beyond that. But anyway, I understand these are all the practical problems. So you would also go for dabrafenib, trametinib.
Yes.
Dr. Shruti, same? Dr. Shruti, unmute yourself and just say same or no. Dr. Indu, are you there?
Yeah, can you hear me?
Yes, Dr. Indu. What would you do in BRAF positive? You disappear in between.
Yeah, I think there is some network issue. So yeah, I agree with my panelist and.
You agree with your panelist. Okay, Dr. Kancham, can you mute yourself, please? Okay, you agree with your panelist. Dr. Shruti? Dr. Nilesh?
For a BRAF V600E, this is the treatment of choice. For non-V600E, there are other things to discuss.
Okay, so Nilesh, since you are there last, there is not a category 1 defined on this BRAF positive patients. Everything is category 2A.
So that is
Yeah.
So firstly, the number of patients are really low. I mean, we're talking about 2 and 3 and 4% of patients. The studies that are there have mainly used dabrafenib and trametinib or verumaferib. And having said that, in many of the situations, these patients are not picked up in first line. Of course, off late, since we are investigating them earlier, we do pick them up first line. And the other treatment options, like for example, chemotherapy, we know that these patients don't do well with chemotherapy. They have aggressive disease, and by and large, it's a very resistant subtype of tumors.
Okay. What is your personal experience with Dabra and trametinib, Nilesh?
I have it in 2 patients. One actually a pediatric melanoma. So there the patient has tolerated very well, but the adult patient who's used it has not tolerated well, with rash and diarrhea being a major side effect. Of course, it's prohibitively expensive, and that's where the challenge for the combination is.
Right, absolutely right. Dr. Vivek, would
Yes,
you
sir.
use IO if the patient has, PD-L1 positive? For example, the same patient has PD-L1 90% positive, and we do not have any category
Yeah,
one recommendation.
so BRAF mutant patients, they tend to have PD-L1 positivity. Is that what is seen?
Correct.
And I would, sort of give IO once we have failed the BRAF treatment and run out of other treatment options. Because usually in the patients with mutation, driver mutations, they don't do well on IO. And BRAF mutation also, we don't really have a very great data of IO doing well. But of course, I think, concurring with what Dr. Nilesh said, the cost is definitely a big prohibitive factor when we want to use dabrafenib, trametinib. And both my, all my dabrafenib, trametinib, 3 of them actually are patients of colon cancer. But, in lung cancer, I've yet to use. So I've had the 2-3 BRAF mutant positive patients where I've used chemotherapy, and then I've put them on maintenance with sorafenib. There is some data, not as good as dabrafenib, trametinib, but probably it may also work.
Right, perfect. I think everybody agrees, and we are running out of our time. So I would just like to conclude by saying that in BRAF mutation positive V600E, all the panelists want to use oral combination of dabrafenib and trametinib. If finances is not an issue, even though there is no category 1 recommendation and there is no phase 3 data, but based on the data available so far, everybody wants to use that. Nobody would want to use IO first line, even though PD-L1 is 90% positive, because there's an activating mutation which is there, and we have a target available for that. It is very surprising that in melanoma, immunotherapy versus targeted TKI, both are going neck to neck. Nobody is sure which one to use, but in non-small cell, we are here at this point. In terms of ALK, we all discuss. If any of the panelists has any point to put forth, otherwise we wind up and back to Dr. Bharat Chauhan and organizers. I hear that nobody. Yes.
Thank you.
Thank you very much. It was a very interesting talk.
Thank you so much.
Thank you, Amish sir.
Thanks,
you.
Amish.
Thank you. Bye. Thank you, everyone.
Bye, Amish. Thanks. Finally, got all of them on the panel.
So for the next session, we like to invite Dr. Vikas Sati sir for his talk on optimal management of ES, small cell lung cancer early stage.
So good evening, everyone. Hope I am audible and my slides are visible. Thank you, organizer, for giving this opportunity. The topic that is given to me is the newer update in management of small cell lung cancer, mainly the extensive stage. So coming to the epidemiology and the current scenario of small cell lung cancer, we know that the prognosis of the patients of small cell lung cancer is bad. As compared to the non-small cell lung cancer, the survival is very less. The globally, small cell lung cancer is estimated to account for around 15% of all lung cancer patients. With the number is more than around 3 lakhs, and about 10% of these patients present in US. And although the SLCLC is not as prevalent as non-small cell lung cancer, it is associated with higher mortality. If we discuss about the Indian scenario, in our country also, it is around 15 to 20% of all lung cancer patients, and majority of patients, around 70 to 90% present in extensive stage. So we know that for the management purpose, we divide these patients into two categories, the limited stage disease and the extensive stage diseases. The treatment for limited stage disease is the combination of chemotherapy plus radiotherapy. But for extensive stage patients, we are left only with palliative chemotherapy. There are some published data from AIMS and also from the ADAR emphasizing that the prognosis of these patients are poor and median PFS varies between 6 to 11 months. So what is limited stage diseases? So it is defined as the single radiation port. The disease is limited to one hemithorax without regional lymph nodes. Anything apart from limited disease will come into the category of extensive stage small cell lung cancer. So this disease is basically a chemosensitive disease. Most of the patient do respond. You can see in the limited disease and extensive stage disease, the response rate varies from 60% to 70%. But the main problem is the relapse. Patient relapse within a very short span of time. Approximately 80% of limited disease patients and almost all patients with extensive disease are going to relapse. This is how the treatment evolved in last, you can say 30-40 years. The first combination which was approved in 1985 is cisplatin plus etoposide. Later the carboplatin, another platinum was also available, and it was also combined with etoposide. The second chemotherapy regimen which is approved in these patients is topotecan, the IV as well as the oral. And then comes the era of immunotherapy. There are two immunotherapy drugs, Atizo and Durva, which has been combined with this chemotherapy regimen. So there is unmet need in this patient management because patient with small cell lung cancer lives less than a year after diagnosis, and improving durability of response. We have seen in the previous slide that these patients do respond, but the durability of response is the main problem. The second problem which these patients will be having is the brain metastasis. At the time of diagnosis, around 10 to 20% of patients will have brain metastasis, and over the time, around 40% patients develop brain metastasis. So the management of brain metastasis is also a problem. Coming to the immunotherapy, we know how the immunotherapy works. Immunotherapy plays an important role in eliciting an anti-tumor cancer response by modulating the patient's own immune responses. And we know that the tumor with high mutational burden like melanoma or RCC, they respond well to immunotherapy. So small cell lung cancer is also a tumor with high mutational burden. So coming to the study phase 3 trial, the Caspian trial. This was a phase 3 open label global randomized trial in which the patients with extensive stage small cell lung cancer, they were randomized into two arms. The stratification was based on the type of platinum they received, either carboplatin or cisplatin. The one arm, the experimental study arm, received the durvalumab in the dose of 1,500 milligram plus the platinum doublet every 3 weeks up to 4 cycles, and after 4 cycles, the responding patient was put on durvalumab maintenance. And we can see the frequency also was changed from 3 weeks to every 4 weeks. In the other arm, patient received the platinum doublet EP, and they can go ahead up to 6 cycles, and the prophylactic cranial radiation was optional. The primary endpoint of this trial was overall survival, and the secondary endpoint was PFS, response rate, quality of life, and so on. Coming to the patient baseline characteristic, the median age in both the arm was 62 years. Majority, so around 70% of the patients were male. There were around 13 to 15% patients were from Asian, but I don't know whether we belong to Asian in this study or not. The patients with performance status of 0, 1 was 35 versus 65, the disease stage 3 versus 4, around 10% were in stage 3. The rest, majority of the patient has stage 4 disease. Most of the patient was a smoker, and as we have discussed about the baseline, 10% of the patients do have brain metastasis. Coming to the treatment exposure, majority of the patient, around 80% of the patient, receive carboplatin with etoposide. And number of cycles, more than 4 cycles, majority of the patient has received 86 versus 84%. As the 6th cycle was allowed only in the EPM, the chemotherapy alone arm, it was given only in the 56% of the patients. So here we can see that after around 44% of the patients also did not completed 6 cycles of chemotherapy, although the median number of cycle was 6 in the EPM and the 4 in the Durva plus EPM. Median total number of Durvalumab was 8 weeks, and the total number of Durvalumab doses was 7. So 4 with chemotherapy and another 3 as a maintenance. Coming to the patient disposition, so around 12% of the patient was still on Durvalumab maintenance, and majority of the patient, around 70-80% patient, completed the treatment. So this is the updated overall survival data of this trial, and we can see the 3-year survival was 5.8% versus 17.6%, and the median OS we can see it is 10.5 in the EPM, but while it is 12.9 in the EP plus Durvalumab arm. This is the subgroup analysis, and we can see that majority of the subgroups, it appears that the Durvalumab addition is benefiting each of them. Now coming to the updated confirmed objective response. So as we have discussed, this is a chemosensitive disease. So even with platinum doublets, 58% of the patients appear to be responding, and with addition of Durvalumab, the number is increased to around 68%. The main problem we can see either with the chemotherapy or chemotherapy plus Durvalumab, that their patients progress very fast. But the patients who do not progress in first 6 to 8 months of therapy, either with Durvalumab or chemotherapy, they remain like they keep on responding. But definitely, if we add Durvalumab, the number of such patients are definitely higher. Coming to the management of brain metastasis in these patients. So we know that the patients who has brain metastasis at baseline, they have a dismal prognosis, and there are 4 large data which suggest that if we give prophylactic chemotherapy to this patient, there is some improvement in overall survival. And we also know that once the patient develops brain metastasis, the survival is going to be dismal. So in this trial, let's see what happened with OS in the patients who has brain metastasis. So Durvalumab plus EP consistently improved the survival as compared to the EP arm, whether the patient has brain metastasis or not. We can see the hazard ratio in the patient who has brain metastasis is 0.69 as compared to, and the patients, and the hazard ratio in the patients who do not have brain metastasis, the hazard ratio is 0.74. So I think the both group of patients are benefiting with addition of Durvalumab. Coming to the patient disposable, what patient received after IO plus chemotherapy. So we can see that the patients receiving one subsequent line of therapy is around 40% in both the arm. So the 60% of the patient do not receive any lines of subsequent therapy, either progression of either chemotherapy or chemo plus Durvalumab. And most common therapy which patient has received is chemotherapy, either single agent chemotherapy or platinum doublets. We know that if the duration of the response after completion of chemotherapy is more than 6 months or 8 months, we can re-challenge with even same platinum doublet. Coming to the toxicity or the safety, so we can see the grade 3 toxicity was almost same in both the group. The only thing is the immune related AEs, which was slightly higher in the Durvalumab plus platinum doublet arm, and which is expected. Now coming to the toxicity, the most common toxicity was hematological toxicity, the febrile neutropenia, anemia, and thrombocytopenia. and they were slightly higher in the patients who received chemotherapy. Coming to durvalumab plus platinum approval and guidelines. So the US FDA has already approved this regimen in March 2020, and this was based on this phase 3 trial that we have discussed. And after their approval, all the major guidelines, either NCCN or ESMO, they have also included the regimen as a category 1 indication. So this is the final slide. That the first line durvalumab plus EP has shown substantial improvement in OS, and sorry, and durvalumab is the only IO where we can use either cisplatin and carboplatin, and benefit with durva plus EP were observed across all subgroup, including brain metastasis patients, and more than 22% of the patient were still on therapy. And durvalumab plus EP prolonged a higher response rate and also survival. Durvalumab offer convenient monthly dosing after completion of the 4 chemotherapy cycles, and the safety we have already discussed. It is almost the same as compared to the comparator arm. I think that's all from my side. Thank you.
Hi. So for the next session is on a panel discussion on the optimal management of stage 3 lung cancer. And I'd like to invite Dr. Narayan Kutty sir for the same. Sir, please take over.
Yeah, thank you so much. Thank you, Bharat, for this invitation. And I hope Bharat will give me an invitation for a physical meeting next year, and hoping that everything will be normal by that time. And for those who are not familiar with me, I'm the medical director and senior medical oncologist, MVR Cancer Center and Research Institute, Calicut, Kerala. And joining me for the panel discussion today, Dr. Vikas Sati and Dr. Rohit Malde. Can I see? Can you switch on your video? Can you?
Yes. Drawing.
Yeah. Dr. Rohit. Then Dr. Jacob George is there.
No, sir, he's not there, sir. He won't join, sir.
Then the list, according to the list, Dr. Gunjan Baijal also, has he joined? Because these faces are not familiar to me. And Gunjan, and I can see Dr. Rekha.
Yes, I'm here, sir.
Yeah. Can you just come to the video?
Sure, sir. Hi, sir.
What about Sunil? Sunil is there?
No, sir, he's also not there. So, sir, we can ask Dr. Bharat Chauhan to be in the panel.
Bharat Chauhan, yeah, Bharat. In that case, I saw Amish still online. I should be asked Amish also to join so that he can also contribute. Amish, are you there? No, okay. Then we will go with this panel. This is the case history. 69-year-old male, well-controlled diabetes, non-smoker, cough during COVID, and HRCT showed a left lower lobe mass. No other symptoms. The typical history of a non-small cell lung cancer nowadays presenting with following post-COVID CT picking up a mass. This is the PET CT finding. You can see 2.4 to 2.1 centimeter mass in the left lung lower lobe, along with the subcarinal and left hilar nodes as well. And both of the T size is 2.4 into 2.1, and the hilar node is 1.4 into 0.9 centimeter, and subcarinal is 1.2 to 1.7 centimeter. And this is the PET CT picture. You can see that the T size as well as the location of the subcarinal node. So basically, I just want to know you people are the setting which you people are working. Are you working in a multidisciplinary team, and you have regular tumor boards so that the tumor board consists of thoracic onco surgeon and radiation oncologist and medical oncologist? And suppose this case comes for your tumor board, the all will be putting their views. So Rekha, yeah, you can.
Yes, sir. Certainly, sir. We discuss such patients in the tumor board, and we have once a week tumor board. So yeah, we would definitely discuss this case in the tumor board, sir.
What about Vikas?
Yes, sir. So like these are the perfect cases where we have to sit together and discuss with our colleagues, sir.
Yeah, good. So definitely nowadays we do discuss this kind of cases in the tumor board, and then we will proceed. And you when will you ask for EBUS, Vikas?
So EBUS, like if we are we have to assess the mediastinal lymph nodes, sir. So before deciding surgery versus chemoradiation, in all such patients we have to do EBUS. So the whole tumor we need to assess then only we can go ahead with the treatments.
Definitely. So definitely the EBUS will tell you about the mediastinal staging, and accordingly we can select the patients for surgery versus the chemoradiation. So so this is the staging. The EBUS, the results you have seen, both the subcarinal as well as left hilar lymph nodes were positive. So it will be CT1 and 2M0, and the further imaging MRI brain contrast is normal. So do you recommend NGS or a biomarker panel for all stage 3 disease, Rekha?
Sir, for let's say we are going for surgery, if you're planning for surgery for a patient, then down the line when we have to give adjuvant therapy, we need EGFR mutation testing. We also need the data on the PDL1 testing. So such a patient definitely, but if probably planning a definitive CTRT for giving durvalumab, we don't need PDL1 testing, sir. So I would not recommend for all the patients, only those patients who are going for surgery. Yes, definitely.
Yeah. So do you recommend at the beginning itself, or when you see the post-operative, if the patient is going for
if the patient is going for surgery, on the post-op specimen, sir.
Okay. So and what about PDL1? You said the
yes,
PDL1.
sir.
Okay.
Yes, sir. Yes, sir.
Because
yes, sir. On the post-operative, like
post-operative. So suppose this is the patient is not going for surgery, then would you recommend NGS?
So
or is it essential to get? Is it essential to know about the biomarkers before planning your treatment in stage 3 disease?
So true, sir. Like we can do, but at present we don't have any data to add. Like after chemoradiation, we don't have any data to add any target therapy like EGFR or ALK. So
in fact, some of them are found to be very toxic. When you combine TKI with the chemoradiation, it's not much benefit. So right. So now I will trouble Dr. Rohit. So what is your recommendation? I'm sure that the tumor board, there will be very aggressive surgeons in the tumor board, but do you recommend concurrent chemo RT, Rohit, in this patient? Or what is your...
Looking at the, so looking at the scans, the primary is quite small volume disease. So, the thing is, this is certainly, this patient is certainly suitable for, definitive chemoradiation. So, the thing is, the primary lesion is just 2.1 or 2.6 centimeters. And, that's definitive CTRT would definitely be on the cards. But given that, the thing is, this patient is potentially resectable as well. So, if his if his ECOG performance status is really good, and patient is quite keen for surgery as well. And the thing is, I'm sure the surgeon could do a lobectomy for this particular gentleman. Then surgery is also a valid option in this scenario. And the thing is, it would be an opinion of a surgeon to see whether he would be happy to operate.
What type of cases will be suitable for surgery according to you? Because we are not having a surgeon here, so we are it's not a strict multidisciplinary.
So in my opinion, these are patients who would get away with a lobectomy, so as opposed to a pneumonectomy. So these patients could be potential candidates. They should have a good performance status, 0 to 1. They should be young, 60, 65, biologically fit, minimal comorbidities, and patient should be keen for surgery, followed by adjuvant treatment, which may follow.
So yeah, definitely when there is a low volume disease and there is the media cell disease also is not that high, then definitely we can offer surgery, and depending suitable depending upon the resectability, then we can proceed. Yeah.
Sir, I guess the size of the N2 would probably make a difference here. I mean, if it's bulky and
yeah, it's
then...
not very bulky, no. It's basically 1.2 centimeter here, so
okay.
that makes it suitable for surgery as well. And if the surgeon is
I missed that information. Okay,
comfortable, then definitely. So again, I will put the question to Rohit. Suppose this patient is very fit and eligible for surgery as well, then what would be your choice? Rohit?
So certainly the thing is, in my scenarios where the surgeon wants to know the biology of disease, and many surgeons would insist on induction chemotherapy, maybe 2 or 3 cycles. And the thing is, if the PET scan after 3 cycles shows that the N2 node has disappeared, so these patients are very attractive, and they would.
Excellent. Yeah. So again, coming to Rohit, suppose we are planning. Yeah. Suppose you are planning a concurrent chemo RT. The patient is not fit for surgery. Then would you like to have induction chemotherapy followed by chemo RT in this patient? Rohit, you are not audible. I think there is some connectivity issue.
No. So this patient is low volume disease. So I would. Yeah. Can you hear me now? Am I audible now?
Yeah.
Hello. Yeah. So basically, the thing is, in my practice, if I find tumors which are 4 or 5 centimeter or greater, in those scenarios, I have insisted on induction chemotherapy treatment. The reason here is, there are trials which have shown that if you can reduce the size of the tumor by 20%, the probability of radiation pneumonitis is reduced by 5 to 7%.
So I'm sure Rekha and Vikas also will be giving the same opinion, right? Any difference of opinion, Rekha and Vikas? Then
I agree, sir.
Yeah,
I agree, sir.
Okay. So this is the guidelines, the standard guidelines. We all follow as per guidelines. You can see that the peripheral placed lesion without any detectable lymph nodes in the CT, and the PET CT is also negative, means straight. We can offer surgery, and the media cell staging is required in these situations where there are obvious N2 nodes, and as well as the hilar lesions, and then these type of patients are candidates for media cell staging. And subsequently, if you find there is an N2 and it's a low volume N2, and the surgeon is pretty confident, then probably we can offer after discussion in the multidisciplinary board. Then we will plan for a surgical multimodality treatment. If it is N3, then straight away we will be going for concurrent chemo-RT, then again extensive N2, mediastinal N2 disease, then probably we will take up these patients for concurrent chemo-RT. So these are the patients for mediastinal staging, and otherwise they will be going for the concurrent chemo-RT. And this is very interesting, and this is what Dr. Rohit was telling. This is the update of the Kindle study, and it's again presented in ASCO 2020. You can see that the best results are following surgery. The surgery followed by adjuvant therapy, adjuvant chemotherapy, either the neoadjuvant chemotherapy followed by surgery and then subsequent chemotherapy. You can see that the 3A has got excellent overall survival of 57.9 months, and the stage 2B has got 34.7 months, and immediately followed by the concurrent chemo radiation, which has got 43 months of overall survival for 3A and for 32.4 for 3B lesions. And you can see that the chemotherapy alone or the radiation alone and the sequential chemo-RT are all behind these the surgery followed by chemo or concurrent chemo. So again, coming to this, the patient refused neoadjuvant chemotherapy. And now again, we have discussed about this. Again, Rohit had answered this. Neoadjuvant chemotherapy is not because of the low volume disease, not a very mandatory thing here. So coming to the because what type of chemotherapy you will combine with the concurrent chemo-RT?
So I'm usually using the weekly paclitaxel plus carboplatin, because that is the regimen that we are using in different setting.
Sorry, I didn't hear that.
We are using paclitaxel carboplatin weekly schedule, sir.
Weekly schedule, sir. What about Rekha?
Sir, no, squamous I would use that. Non-squamous I would use Pemetrexed and cisplatin, sir.
Okay, okay. So do you consider the post-op, choosing this chemo regimen? Do you consider the post-RT pneumonitis? Do you find any difference between the regimens?
I haven't had much experience, to be frank, sir. So
okay, okay. What about Vikas?
Yes, sir. So like we don't have too much burdens to analyze.
Okay, okay. So the concurrent chemo-RT, in fact, the choice of chemo is very important, but almost all chemo give the same kind of same instance of post-RT pneumonitis, but the NCCN says it's S1 is slightly better, though it's not available in our country, or even the for that matter, Tagafar combining with the concurrent RT is better in terms of post-RT pneumonitis. And what about Rohit? Your team is using the same Pacli or Immunotherapy?
Yes.
Okay. Okay, same thing. Okay. So the following the concurrent chemo-RT, when will you consider re-evaluation for these patients? Rohit, what is your schedule like? You go for the 60 gray, and or do you use any other schedules like hyperfractionation or any other method?
So usually it's conventional fractionation, 2 gray per fraction, and the doses which we give is anywhere between 60 to 66 gray. So it all depends on your dose volume histograms, how much of the lung that you've damaged, how much the spinal cord, the heart. So we look at all the tolerances, and we like to stay within tolerances. So if we can pull to 64, 66, we would. But many of the times, the esophagus, the heart, the lung, these are all dose-limiting organs. And 60 gray is a very, very reasonable and decent dose, which is got a good tumoricidal effect along with chemo. And in terms of assessment, we would go for a scan maybe 6 to 8 weeks post CTRT.
Okay. Okay. So till that radiation changes settles down.
Settle.
Yeah. Okay. Okay. So what about Rekha? When will you ask these patients to come back to you for a reevaluation?
Yes, I guess 8 weeks, and probably that's the time when we would want to start our consolidation chemo or durvalumab. I mean, patients who can't afford durvalumab, consolidation chemo. Patients who can afford durvalumab, durvalumab.
So that's very interesting. Do you recommend routine adjuvant chemo following chemo RT? Concurrent chemo RT?
No, sir. I'm sorry. My bad. Yeah. Not for definitive chemo RT. Yeah, actually, 2 cycles of Pemetrexed or paclitaxel. Yeah,
so
can be given for patients who probably it would depend on the response also, sir. If response is, you know, there is residual disease, probably 2 more cycles to consolidate, sir.
But again, that extended study, that lung study, the
lung,
yeah, that's shown in no benefit for following concurrent chemo RT. Adding adjuvant chemotherapy doesn't have any role at all. What about?
I think
yeah,
there can be 2 indication of adjuvant chemotherapy. Although patient who has received the complete chemo radiation may not be benefiting with adjuvant chemotherapy, but if we have given the Pemetrexed plus cisplatin as per the proclaimed data, if we are not using the durvalumab, that is a positive trial. So like if in patients of adenocarcinoma, where we have given cisplatin plus Pemetrexed, the 2 cycle of adjuvant chemotherapy can be given. And the second indication, what NCCN recommends, the patients who like could not receive the full course of concurrent chemotherapy due to whatever reason, they can also be given 2 cycles of chemotherapy at completion of radiation.
Yeah, but the benefit is very minimal because that's what the studies have shown. So
Yes,
I believe if they are, if probably you can complete with the concurrent chemo RT and offering adjuvant chemotherapy may not be of any use. So how will you evaluate these patients? Do you ask for a PET CT or a ordinary CT, the contrast CT scan, or MRI thorax?
A routine CT scan.
Routine CT scan. What about Jacob?
Yes, so routine CT scan, sir. Whatever was done at the baseline to compare. And
so suppose the baseline is PET CT, then do you ask for a PET CT?
CT scan, sir, because the CT component is what we want to look at.
Yeah, that's what we all do. And what all other investigations you will ask? Definitely the pulmonary function test and echo, just to find out how patient is recovering from the RT side. So this patient unfortunately developed breathlessness and with some limitation of activities, and then the CT scan showed radiation pneumonitis, though there are no obvious mass seen. And now the question is how to manage. So what is your protocol, Rohit, in your who will be seeing this patient first?
So it will be the medical oncologist. So it will be the medical oncologist who will be making assessment, and basically, if need be, these patients may have to be hospitalized. They would be assessed. They would be given steroids. So steroids will be the mainstay of treatment to try and control this radiation pneumonitis. We would chip in and we would join in the management component as well. Antibiotics may have to be used as well. These would be assessed. They would be given IV fluids. Electrolytes would be corrected if there are any problems, and it is conservative management.
Jacob, how long you will be using this steroids?
Frankly, I don't. I haven't had a patient, sir.
Now, what about, because actually we can start tapering from the fourth week and by 6 weeks. This is what we follow. What about?
Yeah, so it depends on like the severity, how severe pneumonitis is, and how the patient is responding to steroid.
Okay,
that is also important.
Okay. So now the question is, when will you start durvalumab, if at all the patient is affording, and if at all you want to use the consolidation, when will you start durvalumab after the concurrent chemotherapy?
4 to 6 weeks probably.
Trial, anywhere between 6 to 10 weeks is quite reasonable to start.
Yeah, that's about basically 6 weeks, Rohit. The standard approach is, according to the Pacific, it is about 6 weeks. But many times the real-time data shows that about 50% of the patients have received even after the 6 weeks. As you said correctly, it's about 10 weeks time. But there are studies and with the other immunotherapy as well. They all they all recommend the earlier the better, and if possible by second week. But I think in practice, we don't see the radiation pneumonitis getting subsided by the second week, and the patient won't be fit enough to receive the immunotherapy. So most likely they are going to receive beyond 6 weeks. And again, these patients are also found to be benefited by this. So have you ever used Rekha and Vikas the Nivolumab in your practice?
I have not used it.
Yeah. Okay. So what about Rekha?
No, sir. And I have not used, sir. I haven't had a patient.
Okay. So so the Nivolumab is indicated and approved in the management in India as maintenance therapy, and in those who have an unresectable stage 3 NSCLC and have not progressed on platinum. Basically, this is according to the Pacific trial, where beyond following the concurrent chemo radiation, especially the taxane, and especially the platinum-based concurrent chemo radiation, if the patient has not progressed, then these patients will be taken up for Nivolumab maintenance and found to have overall survival advantage. So that is why Nivolumab is indicated and approved as a maintenance therapy in those who have unresectable stage 3 NSCLC and following the concurrent chemo. And if you look at the various patient characteristics of the patients who got enrolled in the Pacific study, you can see that there are different. All the groups have included in the study, and you can see that it's almost the Pacific study was 2:1 randomization. So you can see stage 2, stage 3A and stage 3B are almost 250 and 212, and the placebo is 125 and 107. You can see a good number of EGFR mutated patients as well in the study. And again, as we mentioned in the earlier part of our discussion, some of these patients have received, about 26% of the patients have received induction chemotherapy first, and then subsequently these patients have taken up for concurrent chemo radiation. And you can see that this is the updated PFS data. You can see that the curves are divergent even after 4 years of the study, and you can see that the updated PFS at the end of 4 years, it's about 35.3% in Nivolumab compared to 19.5% in the placebo, and with a hazard ratio of 0.55. And so the first and only approved immunotherapy to show sustained and durable PFS benefit at 4 years. So this is the study results say, and this is about the updated OS benefit. You can again see that at the end of 4 years, you can see 49.6% of patients got the OS advantage in the Nivolumab compared to 36.3% in the placebo, with a remarkable hazard ratio of 0.71. So that shows that almost 50% of the patients taking Nivolumab were alive at 4 years. So that is the important message we want to give today. It's about the consolidation with Nivolumab after concurrent chemo radiation. In those patients who have not progressed after concurrent chemo radiation will be alive. 50% of these patients will be alive after 4 years. And this is looking at the overall response. You can see that in the Nivolumab almost 80% the combined partial and stable disease. If you look at this response, you can see that 80% of them responded, and the median duration of response is still not achieved, not reached. And the data at the time of the data cut of the ongoing response seen at even at 18 months is about 72.8%. So it's about the durvalumab and the 40 again the real time study analysis of 365 cases. It's about 40%. I have told you earlier that 40% of patients were initiated on durvalumab after 42 days post chemo radiation. This is because of the various complications, and the responses were similar to what observed in Pacific study, despite almost 40% of them started beyond 42 days. And one important question which I was discussing in at the time of diagnosis, should we do the EGFR mutation, because the people are very skeptical when the EGFR is positive, whether to offer TKA or whether to offer concurrent chemo. You can see that I told you the Pacific trial, there is enough representation of EGFR positive patients. So you can see that even in the EGFR positive subgroup, there is a benefit of concurrent chemo RT, and again, such patients will be benefited by giving subsequent consolidation with the durvalumab. So if you look at the survival, overall survival with conventional chemo RT alone, you can see that 5-year overall survival is only 15 to 25%. And if you look at the Pacific trial, the concurrent chemo radiation followed by durvalumab, 4-year overall survival is almost 50%. It's almost double of what we see in the conventional chemo RT alone. So that's amazing, and so this much results you won't see with any other either with the other immunotherapy agents or with any other treatment modality like continuing TKA following concurrent chemotherapy and so on. So if you look at all the parameters, it is very interesting. It's for 47.5 months of overall survival and 17.2 months of PFS. And this is, mind you, this is a treatment is a curative one and only treatment option in stage 3 disease which improves survival. So it is clearly the standard of care in this setting. And even if you start beyond 42 days, the 42 days is the standard period by which one has to start the durvalumab. But even if you start beyond 42 days, these patients are still having a benefit, and it is comparable to the original landmark trial of Pacific study. So I think we come to the end of this panel discussion, and I hope all of you have enjoyed. And even at this time, it's already late, but still we could generate some discussion. And I thank all the panel members for joining me and contributing. And thank you. Back to Bharat. And before handing over, you have any important points to be discussed? I'm sorry.
Dr. Warrior, and one simple question, in your first slide, you mentioned, would you do a PDL1? So you haven't shown the post-hoc analysis of, the Pacific trial, where if PDL1 more than 25% positivity, 1 to 25% positivity, and if the PDL1 is less than 1% positive. So would you use durvalumab in all these 3 conditions?
Irrespective of that, the PDL1 status, we can definitely use durvalumab as consolidation, because this is actually not really benefiting, not really changing the response.
So basically, the European Union, the European Commission, advised this analysis, and in Europe they do not have a license to use in less than 1%. As if you look at the hazard ratio, there is no improvement of durvalumab in those subset of patients where PDL1 is less than 1%. Whereas in the other two, the hazard ratio is...
that was a mandatory evaluation to be submitted for approval. And actually this analysis the study was not meant for that. And if you look at the forest plot, you can see that only 1% got benefited, and that is why the people advise irrespective of the PD-L1 status.
So it's just a thought that someone is spending a lot of money. If you want to convince them, and if these patients do have high PD-L1, we could say that there's a very high likelihood you're going to respond to treatment. Whereas those patients who are uncertain, who who are going to put a lot of things at stake, who are going to take loans to try and get their money for durvalumab, we might have to think again.
Correct. So I think it is different between suggesting and recommending. So for one patient, I will be suggesting, and one patient I will be recommending that you have very high PD-L1, please, like.
It's going to be really useful.
Yeah.
Double the overall survival and tripling of PFS.
Correct. Very true, sir.
So I think Rohit has made a valid point. I think if the PD-L1 is really high, so that the responses are great and the survival is great. So I think we should be in our country, I think we should be judicious in using these drugs. And
yes.
Warrior Sir has made a great presentation. So I just want to make one comment. I have seen 2 patients till now regarding that radiation induced ILD. Many times they are the condition in which stage 3 disease and you have radiation induced ILD, and you want to start durvalumab, and you also feel that durvalumab can also cause ILD. So in this condition, what I have done is I have used pentoxifylline and also steroid simultaneously, and tapering those steroids, and for the period of 12 weeks I have given that, and after that 12 weeks when the patient has responded well, and then I have started durvalumab. So anybody else has done something else in this kind of a situation, Rohit or Dr. Vikas or Warrior Sir, anybody, because this is a common scenario I have seen in one patient at least till now.
We have used only steroids, and pentoxifylline, though the literature says that you can try pentoxifylline, and even imatinib, I believe the imatinib can be tried, and so
and sir, regarding the starting of durvalumab, should we start exactly at 6 weeks, or we can wait up till 12 weeks?
Yeah, that's what now the real-time data showed that about 40% of the patients are put on durvalumab after 42 weeks, and still they benefited from from durvalumab. So my point was you should not restrict only based only on the PD-L1. Definitely PD-L1 beyond more than 50% will definitely do well, but the benefit can be extended to irrespective of PD-L1. And I take and fully agree with Rohit the point that when somebody is paying that much amount, one has to make sure that it really works. But the trial has proven beyond, and the updates are very much convincing. And if you look at the hazard ratio, it is all very impressive. So I feel that the PD-L1 status one can use, but the benefit will be more when you are using beyond 50%. Yeah.
True, sir. True, sir.
Thank you.
Wonderful
discussion.
Thank you, sir.
Thank you all for the wonderful discussion and the wonderful meeting, and we'll meet again tomorrow for the academic feast. Thank you all.